with 3 brief introductory talks.
Without much ado, let's begin today's CME. It gives me immense pleasure to invite Dr. Deepu George, Consultant Physician, Medical Trust Hospital, to talk about older adults with cancer, a physician's perspective.
Over to you, Dr. Deepu.
It's always nice to be welcomed by my student. Thank you, Ganga, for the kind words. So, it's actually a tough job. I'm actually reminded of Sunil Gavaskar facing the West Indies bowlers, because I'm the opening batsman for a long array of illustrious speakers, and this is my starting wicket. So I hope it's well begun, half done. So I'll start off without further delay, because I have a timer set right in front of me so that I don't exceed my time limit. So my topic for today's CME is basically older adults with cancer. What is a physician's perspective? I'm going to take this talk through various subtopics. Basically, 4 of them. The first 4 will be what I am covering today, the context of this CME. How does it matter to all of you in this room, mainly physicians and general practitioners? What are the statistics literally staring at us? What is the physician's role in cancer care? When will you suspect malignancy? What are the tips and tricks to pick up cases? And the most important point there is picking up early. And the last bit, how to license with Geriatrics Oncology Services, Pain and Palliative Care. Dr. Gino, Dr. Barun and Dr. Surega will be covering in more detail. So my basic perspective is basically, how does cancer bother you much? I remember when I finished my MD, one of my dearest professors, Dr. Vinita Shobha, asked me, so what BM are you aiming to be? So I wanted to get a perspective about what she thought we should take. And her first suggestion to me was to take oncology. And my reaction was, man, I don't think I'm that battle hardened to face all this. So that is the reaction of most physicians, and I have to honestly say that it is scary for most of us as doctors. So it is important that physicians take up the lead role here. Why is it important? Because a physician's role in any healthcare providing system, whether it's a clinic, whether it's a public health system, a referral center, or even a super specialty center, it remains pivotal. Senior physicians like Dr. Sujit and Dr. Ramakrishna will tell you that they started off as the epicenter and axis of the whole establishment years and decades back. And I still feel those as junior physicians are coming out right now might not agree with us immediately, but they are second to none and they are irreplaceable in any health setup. They're the first contact, the focal point of reference to most diagnostics, all specialists, and they have to guide regarding treatment options and most importantly family counseling. And as physicians, we have been respected and valued by our colleagues, our patients and relatives, and it's a huge responsibility on our shoulders. So, but the problem is the era of micro subspecializations are here to stay, and it gives us huge challenges to update ourselves and stay abreast in all these fields. And this particular CME is also a humble effort on our side to keep you updated with the latest in something as scary or as averse as cancer care. Now, when you look at the 75th year of independence, or Azadi Ka Amrit Mahotsav as we have been celebrating recently, the life expectancy of Indians have jumped. From 1947, when it was 32, in the 2022 it is 74, and we are looking at 81 years by 2030. Cancer continues to be the second leading cause of death in the US, accounting for almost 1/4 of all deaths. And I will shortly give you the all Indian cancer statistics and the Kerala statistics. So we start with a small little state. This was basically a national cancer registry program which was conducted by the 2 major centers, that is RCC Trivandrum and the Malabar Cancer Center Kannur, in association with the 15 hospitals which had a huge oncology clinic or an outreach program themselves. Basically shows you that whether it's a male or a female, the age-adjusted rates are close to 107 or 127 per million, and we have cancer spread across all the age groups. But the important point here that I still want you all to focus is, even now cancer sites associated with tobacco steal the limelight of bulk of cancers, and we still don't have a legislation against it in a real honest government policy. The clinical extent of presentations can vary. Say for example, if you look at the head and neck cancers, they are highly loco-regional by the time they have diagnosis. But whereas if it is a lung cancer, 61% of the time, by the time we get our hands to it, it's a distant metastasis. Now look at this graph, which shows you that this part is what we are going to focus today. Whether it's males or females, look at the 6th and the 7th decade of the geriatric population. It has a huge spike coming up, whether it's a male or a female population. Basically telling you that cancer is a disease of the elderly. It is 11 times more common to happen post 65 years. And most of the times the troubling part is once it's diagnosed, our elders, they forget that there is a life beyond cancer, there is a life beyond chemo, radiations and the hospitals. They look so lost in these hospitals. So with falling fertility rates of 1 or 2 kid a house and rising life expectancy, the incidence of cancer is on the rise in Kerala and it is here to stay. Dr. Maria just mentioned that 20 to 25% of Kerala is already geriatric. But I would want you to look at it in a slightly different perspective, because you have to count out the non-resident Keralites who might be abroad, and then you are ending up with a huge village of elderly homes, 30 to 35%. Now, lifetime risk of invasive cancers at this age is 45% in males and 38% in females, and elderly cancer care, unfortunately, is a physician's responsibility also. And most of the times, whether we like it or not, referral to oncologist is just one small step in our cancer care. So if you actually look at the number of cancer centers, immediately what comes to your mind? Regional Cancer Center Trivandrum, or an oncopathologist, or a surgical oncologist, or they want the radiotherapy unit, they want the palliative care units. So follow-ups literally cannot happen at such centers alone, and patients often crave to get back home to their familiar family doctor. The risk of relapse, the second malignancies, long-term morbidity of cancer or treatment, they have to be shared with the physicians. That's why we have personally invited all of you from the peripheries to come and join us, because this begs for better interaction and detailed treatment summaries and follow-up plans from the oncology centers like what we are planning to conceive it at Medical Trust. So what are the 4 types of cancer from primary care physician's perspective? You can have basically 4 types of responses to cancer. 1, if you are in a real periphery, you can say, I will do all this by myself. Second, I can say I can co-manage with specialists. Maybe it's happening in Tier 2 hospital. Or you can say that I'm going to refer this patient to another center. Still, there is a 4th response, which I really don't know how many of us can continue doing from now on. That is to say, I don't involve myself with cancer care at all. It's not going to be possible now, because that's the scary numbers that is looking at us. So if you have to look at this and say that I'm going to shoulder a major part of my responsibility towards my patients who might be affected by malignancy today or tomorrow, we have to equip ourselves. So how do you equip yourself as physicians? There are limited data coming across from the literature. Even when I was preparing for these slides myself for the talk, and I found very few literature data. Survivorship care plans were what was conceived in the US for ongoing cancer care programs in the USA. There are formal training at CMEs, I'm sure, at RCCs and Calicut. But limited CMEs happen even at local and national forums. And I still remember the APICON, which happens all over for physicians. And invariably, the oncology halls are the least attended. Because somehow we are averse to this, and I'm sure even now we are left wondering, what is my role in all this? There is a huge lack of time and a workload. I'm sure still people are going to trickle in through these talks, because finally they have to finish their workload in front of them. So there can be 3 basic sets of cancer care. Either you can share it with your colleagues, you can have a parallel system, or you can have a sequential system. But these are all established cancer care models which really do not have one advantage over the other model, because they all seem to be working in various stages in various parts of the world. And pain management and psychosocial support probably come easier to most primary care physicians, because that's what we've been doing and that's part of our daily job. But patient-specific guidelines and treatment suggestions have to come and shared with us from the oncology centers itself. Now, what are the counseling points which are important for all primary care physicians? One is to establish the goal of a cancer care at the cost of the prognosis. You have to assess the patient's preference in cancer treatment options, which is very, very important. What comes first? Is it surgery? Is it radiotherapy or chemotherapy? Is there a possibility of partnering in clinical trials? Because there might be fantastic drugs in the pipeline which might not be accessible to everyone. And obviously the last 5 is basically thrust on the physicians, which I will show you from the trials. managing comorbidities, assessment and treatment of depression, establishing an end-of-life care plan, a referral to a hospice, or even simple opiates and pain relief. They are all basically the physician's job itself. So because of this raging disparity of burden of cancer and the growing and aging population and an acute worsening of shortage of oncologists, how short are we? I'll give you the numbers. There's less than 2,500 seats in 156 medical colleges in the NEET counseling this year, 2021. And there is little in the literature even if you want to update yourself on the oncology case. So basically I had to go through the CAM course, that is the Cancer Care Outcome Research and Surveillance Consortium data from US with great help from Varun himself. And I found that the older physicians, the busier physicians, the referral center physicians and the teaching faculty physicians showed more role in cancer care and they were more reaching out to the cancer affected patients. So in the setting of resource limited settings like our country, oncologists and primary care physicians have to have a high level of coordination and this begs for future research and investments. So this CAM core survey is basically what I'm going to show you shortly. So if you look at this, there is the roles of primary cancer care physicians, which is the PCPs, and the cancer specialist award is written as CS. So establishing the prognosis and goals, you can see this is co-managing, that is the brick color, and most of the times primary care physicians, by the time they get a diagnosis, they refer out. But when it comes to the next slide, you will see that the bulk of the provision for comorbid conditions is actually still done by the physicians. Treatment of depression, still physicians. Establishing a DNR status, luckily, is shared by both. Referral to hospice is shared, and prescription of opiates and pain management is also equally shared. Now, the final part of my talk, when do you suspect malignancies? You basically have to suspect them in these key points: unexplained weight loss or appetite, or unexplained pains, new lumps or skin lesions, unexplained bleeding, even pyrexias of unknown origin. The bulk of them, when they are referred to us, are not infectious fevers. Disproportionate tests, which even after repetition are continuing to bedazzle you, like a high ESR or disproportionately high alkaline phosphatase or D-range LFTs. And tumor markers are to be taken in the correct clinical context only. You might even pick up incidentalomas on imaging, and importantly, screening protocols in familial malignancy screening programs, and disturbingly, even as part of routine health checkups. So what are the cancer screening recommendations in India? The commonest malignancies are basically breast, cervical cancer, lip and oral cavity, which approximately accounts for 34%. The annual incidence is close to more than 1 million per year. And remember, early detection is the key. Because if you just look at the fourth line, the higher mortality rate with late diagnosis of cervical cancer, the mortality rate jumps up to 75% compared to just 7.2% if you pick it up early. Why? Because the long precancerous lesions last for close to 1 to 2 decades. And most of the times, these can be picked up by naked eye examination with the correct dyes like acetic acid or Lugol's iodine, PAPS, PR, HPV DNA. These are not exotic tests, but we still don't do it often enough. The third highest is oral cavity cancers. Tobacco in all forms, whether it's smoking, oral use, snuff, it's happening all in front of us. All the tobacco cessation programs. I'm sure all of us laugh at this tobacco campaign when we go to a movie hall. It's there on the print. The gory pictures are there even on the packets. But early access to these sites on the oral cavity makes it probably more easier to screen. So open the mouth, screen them yourself as good physicians. Breast cancer, though the numbers are significantly lower in India, the mortality rates match the Western data. That's probably because of a multitude of reasons to go with. But again, self-assessment of lumps and thickenings, discharge and change in color are the most important way in which you can pick up breast cancers early. There is questioning the role of mammography because of false positives for a mass screening program in younger and thicker breasts, and breast ultrasound seems to be gaining popularity among younger women for imaging modality, and obviously you have to confirm with an FNAC or an ultrasound guided core biopsy as such. Now the other cancers, endometrial cancer counseling has to start at menopause, lung cancer screening especially based on the risk factors of back years, and always club it with smoking cessation. You have to tell them, maybe you still don't have it, but I'm not telling you that you will never get it. And low density CT screening as advised by the specialist. There's going to be a little bit of a dilemma regarding the role of PSA and rectal examination with regards to prostate cancer, which I'm sure the oncologists will get to in more detail. Now, are we trying to get you to screen more? No. even the National Institute of Health has reported unnecessary common cancer screening in the elderly, which we are going to focus today. What is the point in screening for somebody beyond 75 for colon cancers, beyond 74 for breast cancers, beyond 65 for cervical cancers? Because the false positives and the unnecessary follow-up procedures like colonoscopy, which probably looks very benign to us, but the harms are often front-loaded. And how many of us can risk saying, you are unlikely to live long enough to benefit from this screening at this age? And remember, most of the times the packages, the full body checkups, package, master health checkup and camps give us diameters and tumor markers. Patients are absolutely scared out of their skull. They come and tell us, and then we are forced to do unnecessary tests on top of it. So cancer screening, as I would like to quote, is like the barnyard pen of cancers. We are trying to catch birds, rabbits and turtles. And by the time we catch birds, it's too late because they have already gone. These are the most aggressive cancers, those that have already spread by the time they are detectable, like pancreas and biliary tract malignancies. Then there are the rabbits. The most slowly progressive cancers, we catch them before they metastasize and we have a chance of treating them better. Then there are the turtles. There is no need to catch them. They aren't going to go anywhere anyway. In prostate malignancy screening in patients who are older than 75 and CLL. So what are the tips and tricks? It's very simple. Like all good physicians, listen to the history, his story of what he's telling. Good clinical examination. Make the patient lie down, examine them, feel for the lumps, feel for the lymph nodes, feel for the liver, feel for the spleen. No test is an excuse to get the clinical examination out of your way. Relevant investigations, the relevant family and personal history. Look at the old notes and tests that the patient would have probably not noted, even simple things like the weight charting itself. And finally, it's a team approach. So what's the role of a physician once the cancer is confirmed? The scariest specialist in drugs are often the sweetest looking fellow in this room is probably Dr. Varun. But you go to him as a patient, I'm sure you will be trembling, right? Strong as a pillar of strength to all your patients, listen to them, and most of the times we just have to stay here. Help them liaison with all the oncology services. Take your phone, talk to the oncology team, talk to the radiotherapist, tell them that you are known to them. That does a huge role of setting things right. Set realistic goals of life expectancy and help them plan end-of-life care with the family members. I've quoted this because these two are the most scariest things for most patients. You tell a patient that you need inhaler, they'll run away. You tell a patient that you need insulin, they'll run away. And here we are talking about chemotherapy and radiotherapy, which are even scarier. So what's the role of a geriatrician? A geriatrician basically is somebody who has the extra. What is the extra? He has extra bits of time. He is trained to take care of elderly. He will look at the comprehensive geriatric assessment, as Gino will shortly tell you. And there is simple yet effective analysis of the functional status. There are limitations of elderly care that we are not able to fulfill as physicians. We have to assign roles to the family members, and geriatricians really help add life to the years and not essentially just life to the years of the patient. These are simple tips that I don't have to tell all of you as esteemed medical faculty. Stay away from all forms of tobacco. Stay at ideal weight, get moving, and eat plenty of fruits and vegetables. Avoid alcohol as much as possible. Protect your skin. So I am done with my talk right on time. This is my department, and this is the pillars of my department, my postgraduates who do all the job 24/7 for us. And we have the academic programs in Medical Trust. We have DMB in Medicine and Family Medicine right now. And I dedicate my talk to Dr. Babu John Francis, whom we used to call as Bauchai, because I wish he was here to see us present as a CME from the Department of Medicine. This is my alma mater. Whatever I am today is thanks to St. John's. And thank you to Medical Trust for giving me an opportunity to do this talk. Thank you.
Thank you for beautifully articulating your thoughts and statistics into an amazing presentation, sir. Next up, I invite the highly distinguished consultant oncologist Dr. Varun Rajan to talk on geriatric oncology, challenges and a beacon of hope.
Good evening, everybody. In the next few minutes, I'll be discussing about the concept of geriatric oncology, its need in our society, and what are the challenges we face, and how it is going to bring more smiles into the life of older patients with cancer. So at the onset, so this was an article that came in Lancet Oncology last time. So they states that with aging populations expected to rise rapidly in most high-income countries, the field of geriatric oncology will be of utmost importance in years to come. But it is applicable not only to these high-income countries. In the low and middle-income countries like India, it is equally applicable, particularly considering the demographic status of our state. So, what is geriatric oncology? Is it the oncologist implementing the oncology principles to manage cancer in older patient? And is it so? The answer is a big no. It is the oncologist implementing the geriatric principles to manage older patients with cancer. That is incorporating the oncology principles and geriatric treatments together to treat the older patients with cancer. So it is not just about the cancer, it is much beyond that. So it is another concept about elderly. So elderly is a subjective cultural concept that varies from culture to culture depending on a mixture of health-related, social and economic factors. So it is basically a subjective cultural concept. So that is why in some industrialized areas, the 70 years old is a standard cutoff. But in other poorer or more traditional societies, a lower age may be more appropriate. It all depends upon the cultural concept, the health-related issues, social and economic factors. So what is the reality in our part of the world? The problem is enormous because around 20 to 25% of the population in our state is elderly, and in India, especially Kerala, we are facing a phase of demographic transition. That is, the fertility rate is coming down, mortality rate is coming down, and the life expectancy is going up. So all of us are going to see more and more older patients. So adding fuel to the fire, the 60% of the newly diagnosed cancers are in elderly, and 70% of the cancer deaths occur in people aged 65 years or older. And definitely there is an unmet need in modern day oncology. But the other issue is that all these patients are also excluded from most of the large clinical trials, thus making the practice of evidence-based medicine virtually impossible in this setting. What we usually pose to the others, others that we are practicing the EBM. But when we are treating the elderly patients with cancer, we lack the data in that scenario. So the other limiting factor is that we all know about the social stigma regarding the cancer treatment and its prognosis. And so it is highly unfortunate to say that the stigma is rampant among our doctors too when considering the treatment of older patients. And another issue is a caregiver reluctance due to the financial and social issues. So the hard fact is that usually or many times older patients with cancer are not considered for a curative treatment approach despite the tumor being amenable to curative treatment just by virtue of their age. Or some fit older patients may be denied aggressive therapy for fear of excessive morbidity. But at the same time, some frail older patients may receive aggressive treatment leading to morbidity. That usually happens when some enthusiastic son or daughter usually pushes us to give the treatment, or like a son in US actually who is doing this remote control and who is grabbing some information from social media and usually pushes the physician to give the aggressive treatment. So striking the right balance in treatment of elderly patient is really challenging. So That is why ASCO, as American Society of Clinical Oncology, recommends that all geriatric oncology patients should undergo a CGA, that is comprehensive geriatric assessment of various domains, including social support, physical function, risk of falls, cognition, nutrition, medications, common medical disorders, and depression. But the reality is that this recommendation has not been universally followed because of the comprehensiveness of the assessment and also the length of time required to complete it. Usually, if we start doing a CGA in an OP, it will take minimum 30 minutes, or it may take up to 30 to 50 minutes. So, it is not practical in an oncology OPD or in a physician's OPD to practice CGA for all patients. So, there comes the role of a dedicated service called geriatric oncology. So what are the challenges these patients usually face is that I think already Dr. Deepu mentioned all these things, the multiple comorbid illnesses, polypharmacy. Yeah, or actually on an average, usually every patient receives at least 5 tablets for various indications, and the pharmacokinetics and the genomics is different for an elderly patient. And another common problem is the poor understanding of goals of care, what the patient really want. Usually the patient family usually will not allow us to discuss the prognosis and treatment options with the patient. So we are not sure what is exactly the patient preference, what they really want. So poor understanding of the goals of care is a definite issue in our practice, and repeated hospitalization for various indications and selection of biologically or functionally fit patients. Then the issues of elderly like the dementia, psychosocial issues, fall risk, and estimating the life expectancy also. So these are the challenges that we usually face when we are practicing or when we are treating the older patients with cancer. So definitely older patients will dominate the future oncology practice. There's no doubt about that. However, the standard oncology clinical practices are not well equipped to address the unique needs of older adults with cancers. So there comes the concept of geriatric oncology multidisciplinary team. It includes all the specialists of oncology like the medical and surgical oncologist, radiation oncologist, the geriatric physician, psychologist, nutritionist, physiotherapist, social worker, and the home care team. So it forms a geriatric oncology MDT, and I think it will address the need of the hour. So in the next few slides, actually I would like to discuss about the changes or what are the paradigm changes that has happened in the field of oncology actually over the last 20 years, or how it is different from the oncology that was practiced in olden times. So earlier actually as oncologists we were practicing one size fits all business, that is we had only few drugs and we knew only few about the cancer biology. So now the concept entirely changed from the conventional cytotoxic chemotherapy to the targeted therapy. So now we are practicing personalized cancer medicine. So I have included this cartoon only to show the importance or how it works, the concept called personalized cancer medicine. So if you assume this as the breast cancer patients, because all of these patients are breast cancer patients, because all are colored gray. So morphologically or histologically all are breast cancer patients, like ductal carcinoma, lobular carcinoma, whichever. But if you do the molecular profiling in that patient or the tumor, so yes, you can see that each breast cancer patient is different. Each patient is different. So the treatment, so each patient is different based on the prognostic factors, then predictive factors, outcome, prognosis, everything. So the treatment for each patient is also different, and the outcome also will be different. So that is the concept of personalized cancer medicine. So now actually in modern day oncology, we are practicing personalized cancer medicine. So this slide is about the cancer immunotherapy, which is a new kit in the block. So it is not a chemotherapy, it's also a personalized cancer medicine which will augment our immunity and it will tackle the cancer cells. So I have included 2 cases also to understand the importance of personalized cancer medicine and how it is important, particularly in the case of an elderly patient. So the first patient is a 74-year-old lady. She has hypertension and history of CVA. She was diagnosed to have carcinoma of bladder in August 2019. It was a locally advanced disease because metastasis was present to the iliac lymph node. CT urogram also shows a heterogeneous mass in the left PUJ which is infiltrating the lower ureter. So you can see that it's a mass near the left PUJ in a 74-year-old lady. She had a history of CVA and she's suffering from hypertension. So the issues in this case are patient is elderly, she is frail, she had a history of CVA, she is not fit for any form of intensive chemotherapy. So what is the intent of this patient? And patient is not fit for the radical cystectomy also. So the patient is not fit for cystectomy, she is not fit for the intensive chemotherapy. So the only options left was either to give some small dose of palliative chemo or to refer the patient to palliative care doctor. So what is the expected survival without any active treatment in the patient? It is only 6 to 8 months if we refer the patient to the patient to palliative care doctor only. So in that patient, we have done the molecular profiling and that patient's a biomarker called PD-L1, it came as positive. You can see that. It came as 15%. So we have treated that patient with new type of treatment called immunotherapy. So you can see just after 3 months of immunotherapy, almost the tumor has gone. As you can see that just after 3 months of immunotherapy, the tumor almost disappeared. So because of the excellent response to immunotherapy, we are given the radiation also, and now the patient is living happily. She just completed 3 years. So if you actually refer that patient to only supportive care, actually her survival was only up to on an average 6 to 8 months. So it is about the next patient. He is a 69-year-old gentleman. He had no any comorbid illness. He was not a smoker, but he presented to physician with a cough and fever of 1 week duration. So he was treated with some antibiotics and X-ray showed the right upper lobe pneumonia. But in view of actually unresolving pneumonia, after 3 weeks, a CT test was done. It showed a soft tissue lesion in right upper lobe, along with the coexistence, some consolidations, air bronchogram, and also the ground glass capacities. So the CT-guided biopsy was done. It showed adenocarcinoma with a lepidic pattern. As you can see that this whole tumor actually along with some consolidation and ground glass opacities. So we all know that actually the lung cancer is one of the cancer which is having the best prognosis. So actually only available treatment for that actually around 10 years back was only the chemotherapy or surgery. But in the case of stage 4 disease, all these options are not applicable. So again, there comes the role of personalized cancer medicine. We have sent a patient's tumor for molecular profiling and it shows an exon 19 deletion in the EGFR gene. So at present, the drugs approved for EGFR mutations are this. So I have treated that patient with afatinib. So this is again just after 4 months of that drug. It's an oral pill. Afatinib is an oral pill. You can see just after 4 months of the tablet, the tumor almost entirely disappeared. You can see that. So it is the practice in modern day, modern day oncology. The entire scenario has changed, and all these advances actually it changes the lives of millions of human beings. So I have included this photo just as a take-home message. All these patients are patients above 70 years, and all these pictures were taken after the completion of chemotherapy. So, and you can see the smiles on their face. Actually all are genuine, and they are maintaining a good quality of life, and they are enjoying the peace of mind also. So this is my take-home message for all of you. If you approach the patient with commitment, passion, and care, we can make them long-term cancer survivors. That's all. Thanks for patiently listening.
Thank you for such an informative session, sir. Coming up next is Dr. Gino Joy, a brilliant consultant geriatrician of Medical Trust Hospital, to talk on the need of the hour, how to do a rapid geriatric assessment in primary care practice.
Good evening, everyone. Dr. Deepu and Dr. Varun has been talking to you about CGA, or Comprehensive Geriatric Assessment. That's precisely what I'm trying to tell you in the next 20 minutes. CGA, or the Comprehensive Geriatric Assessment, probably forms the core of how we integrate geriatric principles into an oncology practice. We have distributed a small handout that's a Comprehensive Geriatric Assessment form, which we use in our hospital. It's actually a 4-page form. I just made it into a 2-sheet, which you can take home, and you could probably follow with that during our presentation as well. So when it comes to a typical older person, this is what people think about. Probably a frail man in delirium, probably having multiple lines, very sick, and that is exactly why people probably shy away when they hear geriatrics or dealing with older persons as such. But let me remind all of you that these are also probably, some of them still act as college students in their movies. They are very well in our older adult age group. So they are, meaning in our own community, there are people who are leading happy, healthy, elderly life without being branded as too old. So geriatrics is not just about the frail, very sick older adults, but it's also about these gentlemen who are walking around in our midst. All of us would have probably seen multiple geriatric patients among us. Probably some of us in this room might also qualify to be in that age group. But what we see is always a camouflaged appearance. This is from the movie Ee Parakam Thalaiyam. I'm sure many of you would identify this character. This bus, Thamarakshan Pilla, was a very popular character at that point. Thamarakshan Pilla, Dilip and his friends camouflaged it for the marriage function, as you would remember the story. And they were quite successful in hiding all the issues with the bus. But what is a real Thamarakshan Pilla? The real Thamarakshan Pilla is probably an engine which is not functioning, the headlights not working, no wipers, probably the paintwork is gone forever. So only unless and until we unveil, we pull out the strings attached, we would really find the hidden Thamarakshan Pilla. And that's precisely the job of a comprehensive geriatric assessment. So let me help you discover the Thamarakshan Pillas inside you as we go ahead with this talk. So what happens with these Thamarakshan Pillas? It's very simple. As we age, if I say my age is 82, my heart is also 82, my kidneys are 82. So as you age, your organ systems are aging as well. So at some point, the balancing, when you have an external, an insult, an illness, the balancing of these organ systems in response to the external insults vary, and at one point you will progress, as you can see below the slide, from a very robust state to a very frail state or a dependent state. Fragility, a term which we geriatricians love to use. It probably nothing very sophisticated as it would sound. It means that the patient is very susceptible to external injuries, and the way they recoup from that would be very difficult. And as you look at the slide, most of the geriatric problems, most of the issues what we see in older adults can be probably pinpointed to a frailty as a center concept. So what is the role of a geriatric assessment or a CGA? It comes somewhere here. As people progress with their illness, They progress onto a stage of more frailty. They progress on to require more palliative support, hospice care, and even death at the end. And that's when we intervene with a comprehensive geriatric assessment with the right, and then try to modify things in their favor. So yes, we ask for comprehensive geriatric assessment, and what do we get? We get patients who come with health checkup packages to you. So often in OPD you wonder, looking at a 92-year-old man walking with his estrogen reports, God only knows what was it done for. And you really don't know what to deal with these reports, because there are multiple labs and other service. Medicines for them. So what should have been done instead is a comprehensive geriatric assessment, which would probably not look at the numbers, but try to look at them as a person, what they have been going through, what is their comorbidity burden, what are their geriatric symptoms, as we will come to the rest of the presentation, identify them, see what can be done for them to prevent the progression and prevent a stage of frailty in them. So to begin with, the first step of CG, as you would see in your handouts, we collect more demography from MBBS. And you need to find who's going to take care of this patient after the son returns. Financial independence, because we assume that our patients are independent and they can pay for their bills. I learned it hard way from CMC that you ask them on face, how much monthly income do you have? You must be surprised that some of them would say that I have a pension of 10,000 from which I have to still support my son. There are children who are depending on their parents still in Kerala. So how much they can dedicate for a health care? These to ask them, but believe me, once you ask, they will give you the information. And I always make it a point to identify a primary hospital or primary doctor who is taking care of them. Because once we fix the acute issue, we need a license with their own family physician who that doctor more than anybody else. Comorbidity listing. The patients often would come up to you and say, Doctor, I have sugar and pressure and cholesterol. But then beyond that, we need to sit them up and ask, when did your diabetes start? What are your diabetic complications? How long you have been taking medicines? Unless you make a problem list of this regard, it would be very difficult for you to infer. Assessment is like a passport of the patient. When we prepare a discharge summary, often I get mocked by my medicine fellow friends that you have taken one page for the diagnosis alone. But I believe that one discharge summary which you take out after a comprehensive geriatric assessment should was reported in 1998. No point in attributing this right upper lobe pain, the upper zone pain to cholecystitis. It has to be very crystal clear, because like my HOD who's here, rightly here, she always used to tell, this might be the only opportunity that patient got to come to a hospital and get fully evaluated. So it's the duty of the primary very painful process, because as you know, geriatric patients, the older adults, would be probably consulting a cardiologist, nephrologist, psychiatrist, neurologist, and n number of doctors. They would be having different medicines with them. We make it a show you, because they would say, and you open the Pandora's box and you will find that there has been medicines for multiple indications which the patient doesn't know. So sit with them, you can use a form like this, ask them what is this medicine taken for, ask what the doctor, or you can even call up the doctors and ask whether this medicine is really indicated to be. Point is mandatory, because significant drug interactions and drug related problems are probably the biggest menace with any older adult per se. We also include a vaccination status in our CGA. Many older adults and many of us are not aware that people above 60 are supposed to get vaccines. People look at me with surprise, vaccine, But yes, beyond COVID vaccines, they're supposed to get their influenza booster shots every year, pneumonia vaccines, zoster vaccines, tetanus vaccines. So unless we tell them and ask them, the patient wouldn't be aware that this we are supposed to do. And once we remind them, they come back very faithfully and take their vaccines, and many of these diseases and admissions can be actually prevented and averted. So coming to functional status. In functional status, there are activities of daily living and instrumental activities of daily living. Let's look what they are. Activities of daily living are the basic things which one should be able to do to have a normal life. Like, to keep their hygiene, to, move from one place to another place, eat by themselves. So, like you can see in the handout, we have included a Barthel's index where a point out of 20 is used to see what these patients can do. It's very prudent and very important to document a Barthel's index right at the beginning, because as they go through probably an oncology treatment or in a surgery, we should reassess them what they could do before. If they could walk by themselves before and they cannot walk by themselves now, it has to be documented and found out. Instrumental activities of daily living are a little more, going out and shopping for themselves, cooking for themselves, doing their finances and banking by themselves. We should make a note of these things also to see what decline our patient has every year. Mind you, you're dealing with older adults who would have more problems this year, next year, same time. They will be not looking same. They will definitely have more problems, and we should be able to catch them before they have. Coming to geriatric syndromes. So what is about geriatric syndromes? Prayatinte doctor, the kind of issues what we blame on their age. You say some memory issue, prayatinte. Manasinu vasham, prayatinte. Muttinu kaalina vedana, prayatinte. But these are syndromes. These are associations which doesn't fit into one particular category, if you want to name it so, but will have significant implications in the functionality and functional status of older adults. So we will look into these things and how we will screen for this. First of all, depression. See, unless you ask for, the patient would never probably tell you this. Especially our Malayali patients, they don't really want to come and tell you this. They would come with vague complaints, and you ask 2 questions. They will tell you, are you feeling depressed? Or rather in Malayalam, I simply ask them, Manasinu velu veshamo undamme? And that's it. I would say that, Dr. CJ and Dr. LC are here. They would agree with me. It will open up everything. Brace yourself for next 10 minutes, because you're going to probably see your patient cry in front of you, because more than what we think, patients around us are depressed. PHQ2 is a very easy questionnaire which you can ask. 2 simple things. Ask them whether they're feeling depressed or low. Second thing, ask them, have they stopped doing something which they used to enjoy before? Many of our older females probably would say, serial news stars especially so after the COVID pandemic. I would say it's a depression pandemic which is hitting our older adults. Cognitive impairment. Probably many older adults would say that I have some sort of cognitive impairment. Some would deny it, but it's our job to screen it. A simple way of screening, do a 3-word recall test. You can all try it yourself. I will give you 3 words and let's see how many of you can recall at the end of the session. My 3 words are 1, apple, tell after me, apple, pen, and bus. Okay? Remember the three words. So what you should tell your patient is, you should say, I'm going to tell you 3 words, you should remember, make them repeat it. So ensure that it's registered to them. And maybe I do it once or twice to ensure that this is reinforced. And at the end of interview, I tell, and that is a clinch. Because if they cannot recall, you have to proceed to what we call as a clock drawing test. If they can recall all 3 words, they are pass mark. Pass mark is there is no more screening or worry about the memory for the time being. So you do a clock drawing test. It's a simple test. Ask them to draw a clock with number from, all the face of the clock should have all the numbers from 1 to 12. You ask them to have a minute hand and hour hand. You tell them a time. Usually I tell 10 minutes past 10 or 6:20 or sometime we tell them. So these are some of the clocks which my patient has drawn. So you would be surprised that many of them would not be able to complete this. See, by doing a cognitive assessment, you would reinforce to the patient that, okay, there is an elephant in the room, there is a problem which we need to address. Many of them would be reluctant to say that I have a memory impairment at this age. But then once you prove it to them, they would probably be willing for more screening and more evaluation. Falls, a very important area, because as you know, hip fracture probably accounts for higher mortality than a cardiovascular disease, because 50% of people who had a hip fracture would probably not see the next Christmas or New Year. So this is very important. You should ask whether they had even a single fall during the last 1 year. If at all they had a single fall, whatever be the cause of it, they need a proper assessment of their gait, balance, for which we use our physiotherapy service. Further, you should also look into what triggered the fall. Was there a loss of consciousness, a syncope, as we would say? Because many of these things could be very fatal for the older adults and could risk in significant injuries. Most of our patients might be getting wheeled into your OPD. I see most of my patients coming on a wheelchair. But you should ask them, how do you walk at your home? Do you have a walking aid? Are they using their walking aid properly? We can get our physio friends to evaluate, is the height of the walking aid adjusted? Are they using a proper walking aid? Because use of an improper walking aid itself could be a biggest risk factor for the falls. Most older adults who come to your OPD would be saying that I don't have enough sleep, because they would be retired happily at the age of 60, 65. They would be looking forward to a good sleep, 7 to 8 hours of sleep. But unfortunately, God has created in such a way that as we age, our sleep requirement comes down. So if somebody sleeps for 5 to 6 hours during the day and night combined together, that is probably enough. As people who go into 90s, their sleeping duration would be as less as 5 hours. So you need to get a detailed history of whether they have sleep disturbances. We need to have a drug reconciliation look whether there are any medicines affecting their sleep pattern disorders, restless leg. Find out who is a sleep partner with them, because probably that's a person who is suffering because of this fellow sleep disorder. So it's very important to address these issues, and unless you ask, they are not probably going to come and tell you in your OPD anything beyond your usual muttuvedana and kaigalile kadappu. So nutrition, again, a simple screening tool is to ask for loss of appetite, loss of weight. More than 10% of weight is considered significant if that happened over the last 6 months. Always remember to check for their dental status, because probably the gentleman has only 1 or 2 tooth left, and that is why he is not able to eat well. Pluck it out, ask him to throw it out, get a good set of dentures for them, let him enjoy his chicken and beef. So whatever he likes to have, I'm sorry for mentioning that. But then yes, they deserve to appreciate their taste, eat well and be well nourished. Probably you might be giving them a diet plan, you might be sending them to a dietitian. Find out who is buying grocery at their house, who is cooking the food. Probably many of our older adults are resorting to tea and toast diets because they don't have anybody to cook there. So no point in giving them a big kada about a diet plan if there is nobody in place to settle this. And for those of you who want a formal nutritional assessment, we use MNA or the Nestlé's mini nutritional assessment tool, which is a very helpful and easy tool to quantify it. Bowels. Please ask every older adult about any change in bowel habits, any constipation, any incontinence. I keep this chart on my laptop, my computer desktop in my office. People smile at me and ask, doctor, but then it's very relevant. If somebody is passing stools as the first one, type 1, Malayalam they would say Artikata Bole. Now rapid droppings is probably elite English Polish way of describing that. But then if they are passing stools of that nature, that amounts to constipation. It's not a good stool. So unless we show them this slide or show them this picture, you're not going to get a history of a proper bowel movement. Ask about urinary complaint, whether they have incontinence, whether they have difficulty in holding urine, how many times in night they need to go to void. Even more than one time, if somebody gets up to pass urine in the night, that is considered significant and that needs further evaluation. A simple thing which all of us shouldn't forget to test is a vision assessment. Dr. Rose is here, she would also appreciate that, many people actually delay their cataract surgeries thinking that this can be delayed. Some eye drops can be put, Ayurvedic drops can be put. But the fact is, it is such a simple procedure, they can get to see what we see. So I tell my patients, Amma, you are not seeing enough light as much as I am seeing in this room. And they get convinced. It's a simple examination. If you cannot go to a fundoscopy, at least check for cataracts in your patients. So coming about hearing, these days with the COVID in place, I don't really do much of whispering test. With my mask on, if the patient can hear me when I talk in normal tone, hearing pass. For everything else, you have an ENT person to do a formal screening test and help you with that. Functional capacity, probably for an academic interest. We do routinely in our OPD with the help of our physiotherapist. We do a handheld dynamometer and a timed get up and go test. These values are documented because once a patient goes through a chemotherapy or a surgery or another form of treatment, we always reassess and see what has gone wrong or how the patient is performing at this point. These are very objective numbers we can show the patient and the other treating team members as well. So while it complains to recording their own complaints, we found a lot of complaints for ourselves. The patient came with no complaints and we found a lot of complaints. Now when it comes to their complaints, mostly we find that older adults have non-specific complaints. Probably the highest number of referrals I get in OPD is when the consultant of another specialty doesn't really understand what the problem going on or the patient is taking too much time of theirs. So once you dig into the non-specific timings, non-specific complaints, you give your solid 10 minutes with them. You will dig out a lot. They will open up and they will tell you what specifically is going on in their life. Needless to stress the importance of physical examination. I've just put this here because I always make it a point. I learned from my professor, Dr. Prasad Matthews, always examine your distal pulses, distal powers, proximal powers, and your tone and your carotids. Please at least do these things for every older adult, no matter what complaint they have come with, because you will end up picking up things which matter to them. We have found a lot of problems. Naturally, it will follow with a lot of investigations. Older adults are not coming into our OPD to get another full list of investigations or n number of referrals. They are probably looking at you to optimize things. So whenever investigations or referrals are required, do it as and when required, but not probably overdo it. But what you can do is involve other specialties, involve physiotherapists, involve occupational therapists. We are very proud to say, except the occupational therapists, which I have put in italics, we have everything else in medical trust. I think my directors would make a point and note this, that if we have an occupational therapist on board, probably we are going to be the only center which is fully equipped to run a geriatric OPD in future also. Family meetings, after all your screenings, it's very important to sit with the family, find out who is going to take care, what is end of life decision, who will come and sign a document when it is required. And in India, now a leaving will or advanced health directive is legal. So we could also encourage our patients actually to write it for themselves. Even we as doctors, we could probably put it down. When not to intubate me, when not to put me on life support. Probably this is a trend which should catch up in India, and we can encourage our patients in our CGA. And beyond the clinics, we should probably look at visiting their home. I'm very happy to say that Medical Trust has launched an MTH at Home program where we have a trained physician and a nurse who will visit them, who will see their issues at home, who would even recommend home modifications to make it a very safe environment at their home. So like we say, charity begins at home. Safety of an older adult begins at home as well. This made headlines recently. Ratan Tata started a companionship program for elderly and everybody said, wow, wow, wonderful. What an honor, what a gentleman he is. But, ladies and gentlemen, this is our founder director. 2 decades ago, this gentleman had the vision of starting something special for senior citizens. Till date, in our hospital, we are running a senior citizens health program where we give discounted healthcare facilities, priority bookings, and a dedicated geriatric service. And to top it all, we are probably today inaugurating the 3rd and Kerala's 3rd in the country and Kerala's first geriatric oncology service. So, ladies and gentlemen, we have a strong base. We have someone who thought about geriatrics and senior citizen caring even when others were running behind, starting new super specialty hospitals. So with this thought, I conclude. Thank you for your patient listening.
Big round of applause, ladies and gentlemen, for that comprehensive session. Thank you, Dr. Gino Joy.
Ladies and gentlemen, for those of you who have logged in late, this CME is jointly conducted by Oncology, Geriatrics and General Medicine Departments of Medical Trust Hospital, which aims at bridging the gap between the primary care and geriatric oncology and to promote partnerships in practice and research. A very formal inaugural session, and we have here with us none other. Applause for our chief guest. Sung for almost 4,000 films. I request Dr. P. Lewis. also our medical director, who is the professor of geriatrics at CMC Vellore and is also on the stage. Consultant oncologist, Medical Trust Hospital onto the stage. And I request all our guests to kindly all good things will kindly stand for the prayer song. Thank you. Please be seated. I call upon Dr. Varin for the welcome address.
Good evening, everybody. Warm welcome to one and all who are present here. Thank you to all of you who have gathered here to grace this occasion and also for making this golden years a golden one. Thank you all. So Medical Trust Hospital, since its inception in 1973, has come a long way over the last 50 years with numerous, tremendous, path-breaking achievements in its credit. In continuation to the legacy of Medical Trust, we are now coming up with a new concept which is evolving in many parts of the world. That is the concept of the Geriatric Oncology. It needs much commitment, care, and sincerity. So actually it is the need of in our society, and so it is going to be the first Geriatric Oncology unit in our state and third in our country. So this CME is being conducted in relation to this inauguration. So let's make a start here. It is my great pleasure and privilege to welcome our dearest Managing Director, Dr. P.V. Louis, who has been always our source of inspiration and motivation. Warm welcome, sir. We have two distinguished guests today. We are really honored to have him here for this meeting, who needs no introduction to the entire Malayalis all over the world. He is none other than our versatile singer, Sri G. Venugopal. Welcome. So he is a versatile singer, and I think he is also celebrating his 4 decades of musical life, and we all of us are actually really thrilled to have him come for the inauguration of this oncology unit inauguration. So actually ഒന്നാം കാലം പാടിയും അല്ലെങ്കിൽ നരുമീ ഗാനം തന്നെ പൂട്ടമോ ഇതൊക്കെ നമ്മളൊക്കെ ഇല്ലാതായാലും കേരളം ഉള്ളിടത്തോളം കാലം അല്ലെങ്കിൽ മലയാളികൾ ഉള്ളിടത്തോളം കാലം ഇവിടെ നിന്നൊന്നും പോകില്ല. So in that sense, sir, you are really blessed, and stay blessed for all your future endeavors. And actually we got a golden voice to inaugurate the golden years. Thank you. Then actually I would like to welcome our commercial director and medical director, Dr. P.V. Thomas. He is actually an ever energetic and jovial person who is always a source of motivation to all of us. Welcome, sir. So I would like to welcome our next distinguished guest, who is an eminent speaker, then academician and an astute technician, and she is the professor of geriatrics at CMC Vellore. Madam, welcome to this meeting. We are really fortunate to have her here for this meeting, and we are really waiting to speak her keynote address. So next, I would like to welcome the directors of Medical Trust, our financial director, Sri P. Xavier sir, and then our dear Rose Madam, Dr. Rose P. Pulikal. So welcome to this meeting. And next, I would like to welcome the VIPs of this meeting. Yeah, the specialists, actually the practitioners who are practicing in different part of this district, yeah, especially Ernakulam and also in the neighboring districts like Alapi, Thrissur and Idukki. So actually we are really grateful, delighted, and we are humbled by your presence. So let's give a big round of applause to all the doctors who are come here to attend this function. Next, I would like to welcome the consultants of Medical Trust Hospital. Actually, this entire event is the result of the teamwork of doctors in Medical Trust. Actually, the senior doctors, juniors, then different specialists all worked hand in hand to make this meeting a grand success. So I welcome all the consultants of Medical Trust Hospital. Then I would like to welcome the office staff of our hospital, then administrative staff, nursing wing, then oncology nurses, then the marketing team, PROs, and all the postgraduate students of our institute. Warm welcome to all of you. Then I would like to welcome the print and visual media who are present here to cover this meeting. So thank you all, and I wish you all a very good evening and enjoy the session. Thank you.
Thank you, Dr. Varun. I now call upon Dr. P.V. Lewis, the Managing Director, for the Presidential Address.
Dear consultants and friends, Medical Oncology under the leadership of Dr. Varun Raj has taken off and is doing an excellent work. This CME is to kickstart our oncology program. Plans are afoot to start a radiation oncology center. This will be a standalone center with highly specialized facilities, and we'll have daycare center attached to it. We have already ordered a PET scan which will be available from the last week of September. Coming to another PET project is our MTH at home. With a geriatric patient at every other home, Medical Trust Hospital has come with a novel program known as MTH at home. A family medicine consultant along with a nurse and a social worker will visit this geriatric patient and give primary treatment at home. If further treatment is required, he is brought back to the hospital and further treatment is given. This program has started since 1 month and we have got a very good response. An average of about 3 to 4 home visits are daily conducted. This is done under the leadership of our geriatric consultant, Dr. Jidu, and it's going on very well. On this occasion, I should thank all the consultants and the doctors who have always been a well-wisher of Medical Trust Hospital. And I also should thank Dr. Sureka, who has come from all the way from Vellore to give a keynote address. Thank you, one and all.
Thank you, sir. Ladies and gentlemen, please be very generous with your applause. It also helps in burning candles. Thank you. So friends, as we go on to the inauguration, we first have a brief preview of the Geriatric Oncology Department. We'll have a small video that's being played so that we get an idea of what is there in Geriatric Oncology. To formally inaugurate this evening's program, and I request all the other dignitaries to join him around the lamp. And friends, this will be followed by the logo launch of the Geriatric Oncology Department. Friends, we'll go on to the logo launch of the Geriatric Oncology Department. I request our chief guest and madam to kindly launch the logo. Can we have the video in the background, please? Thank you. I now request Mr. G. Venugopal to kindly address this gathering.
വേദിയിലും സദസ്സിലും എനിക്കെത്തുന്ന ആരാധ്യരായ ബഹുമാനരായ ഡോക്ടർമാരെ, പ്രിയമുള്ളവരെ, ആദ്യമായിട്ട് ഞാനിങ്ങോട്ട് വരാനിടയായ ഒരു സാഹചര്യം വളരെ യാദൃശ്ചികമാണ്. എന്നെ തനു എന്നാണ് വിളിക്കുന്നത്. അപ്പോൾ ഞാനിത് എന്താണ് പരിപാടി എന്ന് ചോദിച്ചില്ല. കാരണം ഞാനും തനുവിൻ്റെ ചേട്ടനും ഒരേ ക്ലാസ്സിൽ ഏതാണ്ട് ഒരേ ബെഞ്ചിൽ 11 വർഷം അടുത്ത് ഇരുന്ന് പഠിച്ചവരാണെന്ന് പറഞ്ഞു. അപ്പോൾ തനുവിനെ കൊച്ചിനെ അറിയാം. അപ്പോൾ ഞാൻ ഏറ്റു വരാമെന്ന് പറഞ്ഞു. പിന്നീട് എന്താണെന്ന് ഞാൻ ഡീറ്റെയിൽ ആയിട്ട് ചോദിക്കുമ്പോഴാണ് എനിക്കിതിൻ്റെ ഒരു നോട്ടീസ് അയച്ചിരുന്നു വാട്സാപ്പിൽ. വളരെ സന്തോഷമുണ്ട് ഈ ഡോക്ടർമാരുടെ ഇടയിൽ ഒരു പാട്ടുകാരനായിട്ട് നിൽക്കാനായിട്ട് ഞാൻ ഏതാണ്ട് മെഡിസിന് 78 കയറി പറ്റിയതാണ്. ഏതാണ്ട് 1% 1% ഓഫ് മാർക്കിന് അന്ന് പ്രീ ഡിഗ്രി കഴിഞ്ഞ് മിസ്സായതാണ്. അത് കഴിഞ്ഞ് ഡിഗ്രി സുവോളജി യൂണിവേഴ്സിറ്റി കോളേജിൽ വീണ്ടും ഡോക്ടറാവുക എന്ന ഉദ്ദേശത്തോടെ എടുത്ത് കയറി. സെക്കൻഡ് ഇയർ ആയപ്പോൾ എല്ലാ ആഗ്രഹങ്ങളും പാട്ടിൽ അലിഞ്ഞു തീർന്നു. അങ്ങനെ പാട്ടിൻ്റെ വഴിയായി ഞാൻ എന്ന് പറയുന്നതാണ് യാഥാർത്ഥ്യം. ഞാനിവിടെ വളരെ ആകാംക്ഷയോടെ കാണണം എന്ന് പ്രതീക്ഷിക്കുന്ന, നേരത്തെ കണ്ടിട്ട് പരിചയപ്പെട്ടിട്ടുണ്ട്, ഡോക്ടർ രാജഗോപാൽ. അദ്ദേഹത്തിൻ്റെ വോക്ക് വിത്ത് വേറി എന്ന അദ്ദേഹത്തിൻ്റെ ആത്മകഥാംശമുള്ള പാലിം ഇന്ത്യ അദ്ദേഹം ഇന്ത്യയിൽ എങ്ങനെ അദ്ദേഹം കൊണ്ടുവന്നു എന്നുള്ളത് ഉൾപ്പെടെയുള്ള വളരെ ഇൻട്രസ്റ്റിംഗ് ആയിട്ടുള്ളൊരു പുസ്തകം ഈ അടുത്ത കാലത്ത് ഞാൻ വായിക്കുകയുണ്ടായി. പത്മശ്രീ കിട്ടിയിട്ടുണ്ട്, ധാരാളം ഇന്റർനാഷണൽ അവാർഡ്സ് അദ്ദേഹത്തിന് കിട്ടിയിട്ടുണ്ട്. ആ പുസ്തകം നിങ്ങളിൽ പലരും ഡോക്ടർമാർ വായിച്ചിട്ടില്ലെങ്കിൽ ദയവായി വായിക്കണം. കാരണം ഒരു ഡോക്ടർ എത്രമാത്രം മനുഷ്യന് വേണ്ടി തന്നെ ഒഴിഞ്ഞു വയ്ക്കുന്നു എന്നുള്ളതിൻ്റെ ഒരു യഥാർത്ഥ ഒരു ചിത്രീകരണമാണ് ആ പുസ്തകത്തിൽ ശരിക്കും കാണുന്നത്, വായിക്കുന്നത്. വളരെ സിമ്പിൾ ലാംഗ്വേജാണ്, ഇംഗ്ലീഷ് ഇസ് വെരി സിമ്പിൾ, യൂസ് ഇറ്റ്. അതായത് ഏറ്റവും ക്ലാരിറ്റിയുള്ള ഒരു മനസ്സിനെ അത്ര സിമ്പിളായിട്ട് അത് ഭാഷയിൽ കൊണ്ടുവരാൻ സാധിക്കും. വർഷങ്ങൾക്ക് മുമ്പ് 2009 ഞാൻ എൻ്റെ കരിയറിലെ 25ാമത്തെ വർഷം പൂർത്തിയാകുമ്പോൾ ആണ് സസ്നേഹം ജീവനഗോപാൽ എന്ന ഒരു ചെറിയൊരു ചാരിറ്റി RCC അതൊരു നിമിത്തമായിരുന്നു അത്. കാരണം ഞങ്ങൾ 4 ഫ്രണ്ട്സ് കാണാനായിട്ട് പോവുകയും അവിടെ നിന്ന് നഴ്സ് ഞങ്ങളോട് ചോദിക്കുന്നുണ്ടായിരുന്നു, ഒരു ഡോക്ടർ ധൈര്യമുണ്ടോ കുട്ടികളുടെ വാർഡിൽ വന്ന് കാണുവാൻ എന്ന് ചോദിച്ചപ്പോൾ ശരിയെന്ന് പറഞ്ഞ് ഞങ്ങൾ 4 പേരും കുട്ടികളുടെ വാർഡിലേക്ക് കയറുന്നു. അപ്പോൾ ലെഫ്റ്റ് സൈഡിൽ ഒരു പ്ലേ ഏരിയ ഉണ്ട്, വളരെ കളർഫുള്ളായിട്ട് കുട്ടികളുടെയൊക്കെ അവർ പലതും ചെയ്തൊക്കെ വെച്ചിരിക്കുന്ന അവരുടെ ടോയ്സ് പോലെയൊക്കെ ഉണ്ടാക്കിയല്ല, ആക്ച്വലി അവർ അത് വരച്ചാണ് അന്ന് വെച്ചിരുന്നത്. ഏതാണ്ട് വാർഡിൽ കയറി ഒരു 4-5 അടി നീങ്ങിയപ്പോൾ ഞാൻ നോക്കിയപ്പോൾ എൻ്റെ കൂടെ ഉണ്ടായിരുന്ന 2 പേരെ കാണാനില്ല. ഞാനും എൻ്റെ ഒരു ഫ്രണ്ട് മാത്രമേ ഉള്ളൂ. ഒരു 5-10 അടി മുൻപിലേക്ക് പോയി കഴിഞ്ഞ് നോക്കിയപ്പോൾ എൻ്റെ കൂടെയുള്ള ഒരാളേ ഇല്ല, ഞാൻ മാത്രമേ ഉള്ളൂ. അപ്പൊ അത് വളരെ ദൈന്യത ഉണ്ടാക്കുന്ന ഒരു കാഴ്ചയാണ്. തൊട്ടിൽ പോലുള്ള കട്ടിലുകളും വളരെ ദൈന്യത നിറഞ്ഞ കുട്ടികളുടെ കൂടെ ഇരിക്കുന്ന ബൈസ്റ്റാൻഡേഴ്സ്. കുട്ടികളുടെ മുഖത്ത് വേദനയാണുള്ളത്, അവർക്ക് ദൈന്യതയില്ല. അപ്പൊ അവിടെ നിന്ന് ഞാൻ പെട്ടെന്ന് എനിക്കിത് കണ്ട് സഹിക്കാൻ പറ്റിയില്ല. കാരണം നമുക്ക് എല്ലാവർക്കും കുട്ടികളുണ്ട്, കുട്ടികളെല്ലാവരെയും നമുക്ക് വളരെ ഇഷ്ടമാണ്. ഞാൻ വെളിയിലേക്ക് ഇങ്ങനെ നടന്ന് നീങ്ങിപ്പോവേണ്ട, അത് ഇത്രയും കണ്ടാൽ മതി. കാരണം പലരും കീമോതെറാപ്പിയുടെ അഡ്വാൻസ്ഡ് സ്റ്റേജസിലാണ്. അപ്പൊ എന്റെ ഈ ഒരു ലോങ് ആയിട്ടുള്ള ഞാനൊന്ന് ഷർട്ടല്ല, ഒരു കുർത്തയല്ല എന്ന പോലത്തെ ഒരു തരം ഒരു കുപ്പായാണ് ഇട്ടിരുന്നത്. അതിലൊരു ടാഗ്, ഒരു വലി. അതൊരു ഇതുപോലൊരു വളരെ ഒരു കൊച്ചു പെൺകുട്ടിയാണ്. ഞാൻ മാമന്റെ പരിപാടികള് TV-യിൽ കാണാറുണ്ട്, ദയവായിട്ട് ഈ ഒരു കാർട്ടൂൺ ബുക്കിൽ എനിക്കൊരു ഒപ്പ് തരാമെന്ന് ചോദിച്ചു. അത് ദാറ്റ് വാസ് ആക്ച്വലി ലൈഫ് ചേഞ്ചിങ് സിറ്റുവേഷൻ ഫോർ മീ. അവിടെ വേണമെങ്കിൽ എനിക്ക് ആലോചിക്കുമ്പോൾ എന്നെ ഓർക്കുന്നു, എൻ്റെ പാട്ടുകൾ കുട്ടി ഓർക്കുന്നു. എന്നെ TV-യിൽ എനിക്ക് മാമനെ കാണാറുണ്ടെന്നാണ് പറഞ്ഞത്. കാരണം TV-യിൽ ഞങ്ങൾ പലരും റിയാലിറ്റി ഷോസിന് വരാറുണ്ട്. അതാണ് ശരിക്കും സസ്നേഹം വേണുഗോപാൽ എന്ന് പറഞ്ഞ ഒരു പരിപാടി, ഒരു ക്യാൻസർ അവിടെ അത് ബേസ് ചെയ്ത് 5 വർഷത്തോളം അവിടെ പ്രവർത്തിച്ചിട്ടുണ്ട് ഞങ്ങൾ. പക്ഷെ ചെയ്യുന്നത് ചാരിറ്റി വിത്ത് ഡിഫറൻസ് ആണ്. അവിടെയുള്ള കുട്ടികളെ ഞങ്ങളുടെ വോളണ്ടിയേഴ്സ് തന്നെ അവർക്ക് ആർട്ടും കൾച്ചറും ക്രാഫ്റ്റും മാജിക്കും ഒക്കെ പഠിപ്പിക്കുന്നത്. ഇപ്പൊ നിങ്ങളവിടെ RCCയിലെ കുട്ടികളുടെ വാർഡിലേക്ക് കയറുന്ന ആ ഒരു പ്ലേ ഏരിയയിൽ മുഴുവൻ ഈ കുട്ടികളെ കൊണ്ട് ഞങ്ങൾ ഉണ്ടാക്കിയിരിക്കുന്ന ശില്പങ്ങളൊക്കെയാണ്, ക്ലേ കൊണ്ടൊക്കെയുള്ള മോഡൽസ് അവിടെ. അത് കഴിഞ്ഞ് ഞങ്ങളുടെ പ്രവർത്തനം ഓൾഡ് ഏജ് ഹോംസിലേക്കും അതുപോലെ പെൺകുട്ടികളുടെ ഓർഫനേജസിലും, പൂജപ്പുര മഹിളാ മന്ദിരം ഓർഫനേജും അവിടേക്കൊക്കെ ഞങ്ങൾ കൂടുതൽ വ്യാപിപ്പിച്ചു. അപ്പൊ ഈ ഓൾഡ് ഏജിലെ ആൾക്കാരുടെ പ്രശ്നം എന്ന് പറയുന്നത് വളരെ വ്യത്യസ്തമാണ്. പലർക്കും ഈ പറഞ്ഞ പോലെ ഇവിടെ നേരത്തെ ഒരു ഡോക്ടർ പറഞ്ഞ പോലെ അവരെ മാനസികമായിട്ട് അവർ വളരെയധികം സമ്മർദ്ദം അനുഭവിക്കുന്നവരാണ്, ഡിപ്രസ്ഡ് ആണ്. എൻ്റെ വീട്ടിലെ എൻ്റെ അമ്മയ്ക്കും അച്ഛനും വെരി വെൽ ലുക്ക്ഡ് ആഫ്റ്റർ. എൻ്റെ അമ്മയ്ക്ക് 90 കഴിഞ്ഞു, അച്ഛന് 96 കഴിഞ്ഞു. ബട്ട് സ്റ്റിൽ അവർ രണ്ടുപേരും അണ്ടർ ഓൾഡ് ഏജ് ഡിപ്രഷനാണ്. അതിന്റെ കാരണമാണ് നമുക്ക് പറയാൻ സാധിക്കില്ല എന്തുകൊണ്ടാണ്. ഈ കുട്ടികളുടെയും വയസ്സായ ആൾക്കാരുടെയും കാര്യങ്ങൾ അറ്റൻഡ് ചെയ്യുക എന്ന് പറയുന്നത് തന്നെ ദാറ്റ് ഇസ് നോട്ട് ഈസി. വളരെയധികം നമ്മൾ ആലോചിച്ച് വളരെയധികം അവർ അറ്റൻഡ് ചെയ്യണം. ഒരു സാധാരണ ഒരു രോഗിക്ക് കൊടുക്കുന്നതിനെക്കാട്ടിൽ എത്രയോ അധികം ശ്രദ്ധയും അറ്റൻഷനും ഈ വയസ്സായ ആൾക്കാർക്ക് കൊടുക്കേണ്ട ഒരു കാര്യമുണ്ട്. അവിടെ ഞങ്ങളിപ്പോ അവിടെ ഓൾഡ് ഏജ് ഹോമില് ദുഃഖകരമാണ് അവിടെ കാര്യങ്ങൾ. കാരണം ഈ നടക്കി തള്ളുക എന്ന് പറയുന്ന അമ്മമാരും അച്ഛന്മാരും ഒക്കെയാണ് അവിടെ കൂടുതലുള്ളത്. മക്കൾ നോക്കാൻ വയ്യാതെ അവിടെ കൊണ്ടാക്കിയിട്ട് ചിലർ സ്വത്തിനു വേണ്ടി ഇവരെ അവിടെ കൊണ്ടാക്കിയിട്ട് അവരെ കൈ കൊടുത്തിട്ട് തിരിച്ചു പോകുന്നവർ അങ്ങനെയൊക്കെ ഉണ്ട്. അപ്പൊ നിസ്സാര പാട്ട് എനിക്ക് വേണ്ടി പാടിത്തരും. അപ്പൊ അവരെ ഒന്ന് കാണുക, അവരുടെ എന്തെങ്കിലുമൊക്കെ അത്യാവശ്യമുള്ള ചെറിയ ചെറിയ കാര്യങ്ങൾ ചെയ്തു കൊടുക്കുക. അവർക്ക് ബ്ലാങ്കറ്റ്സ്, അവർക്ക് അതുപോലെ ചിലർക്ക് വളരെ നന്നായിട്ട് ക്രാഫ്റ്റിൽ താല്പര്യമുള്ള അമ്മമാരുണ്ട്, വയസ്സായ ആൾക്കാർ. അവരൊക്കെ ഈ ചില തോർത്തിലൊക്കെ എന്റെ പടം വരച്ച് അവർ തുന്നി എന്റെ മുഖമൊക്കെ തുന്നി തരും. ഒരുപക്ഷെ വേറെ ഏതൊരു അവാർഡിനും നമുക്ക് കിട്ടുന്നതിനും വാല്യൂബിൾ ആണ് ഈ സാധനങ്ങളൊക്കെ കയ്യിൽ നിന്നും ഞാൻ സൂക്ഷിച്ചു വെച്ചിരിക്കുന്നത്. ഒരു അമ്മ ഒരിക്കലും വന്നിട്ട് മോനെ എനിക്ക് ഇതെന്റെ കയ്യിലുള്ള ഒരു രുദ്രാക്ഷമാലാണ്, ഇതൊന്ന് വെള്ളി കിട്ടിത്തരാമെന്ന് ചോദിച്ചു. വളരെ രഹസ്യമായിട്ടാണ് ചോദിക്കുന്നത്. കാരണം അവിടെ അങ്ങനെ ചോദിക്കാൻ പാടില്ല. അപ്പൊ അത് നമ്മൾ അവർ മറ്റുള്ളവർ അറിയേണ്ടത് ചെയ്തു കൊടുക്കുക. അവർക്കൊക്കെ ഒരു മോനോടെന്നുള്ള പോലത്തെ ഒരു സ്നേഹമാണ്, ഒരു വാത്സല്യം. ജസ്റ്റ് അവരൊന്ന് സ്പർശിക്കുക, അത്രയും മതി. നമുക്കൊരു 4 വരിയോ ഒരു സ്പർശനമോ ഒരു ആലിംഗനമോ കൊടുക്കുന്ന ഒരു മരുന്നിനെക്കാട്ടിലും വളരെ വലുതാണ്. അത് ശരിക്കും ദാറ്റ് ഇറ്റ്സെൽഫ് ഇസ് എ മെഡിക്കേഷൻ. ആ ഒരു അറ്റൻഷൻ എന്ന് പറയുന്നത് എനിക്ക് എൻ്റെ ഒരു ഓർമ്മ മുഴുവൻ ഞാൻ വളരെ കൊച്ചുകുട്ടിയായിരിക്കും, ഒരു 6ാം ക്ലാസ്സിലും അവർ പഠിക്കുമ്പോഴും എൻ്റെ അച്ഛൻ്റെ അമ്മമ്മ അവർ വീണ് കാലൊടിഞ്ഞ് ഹൈലി ഡയബറ്റിക് ആണ് അമ്മമ്മ. അപ്പോഴിവിടെ അന്നിവിടെ പ്രൈവറ്റ് ഹോസ്പിറ്റൽസ് അധികമില്ല തിരുവനന്തപുരത്ത്, മെഡിക്കൽ കോളേജിലാണ്. അപ്പൊ അമ്മമ്മയുടെ ഡോക്ടർ അന്ന് ഡോക്ടർ മാത്യു റോയ് എന്ന് പറയും, വളരെ സീനിയർ ഫിസിഷ്യനാണ്, അവിടെ വരുന്നു. അപ്പോ ഡോക്ടർ മാത്യു റോയ് അന്ന് അവിടെ സ്പോട്ടിലില്ല, വേറെ എവിടെയാണത്, വേറെ ഏതോ വാർഡ്സിലാണ്. അപ്പോൾ മാത്യു റോയുടെ ഒരു അസിസ്റ്റന്റാണ്. ഞാനും അച്ഛനും അമ്മമ്മയെ ഒരു വീൽ ചെയറിൽ തള്ളി. അപ്പൊ അത് നേരെ ജനറൽ വാർഡിലാണ് കൊണ്ടുപോകുന്നത്. ഇമ്മീഡിയറ്റ്ലി പേ വാർഡ് നമ്മൾ അപ്ലൈ ചെയ്ത് ഒരു ദിവസമായിട്ട് വെയിറ്റ് ചെയ്യണം. അതായത് അന്ന് വൈകുന്നേരം അവിടെ ചെല്ലുമ്പോൾ തിങ്ങി നിറഞ്ഞ ആസ് യൂഷ്വൽ ഇന്നത്തെ പോലെ തന്നെ ആ ജനറൽ വാർഡ് മുഴുവൻ തിങ്ങി നിറഞ്ഞിരിക്കുകയാണ്. പല സ്റ്റേജിലായിട്ട് പല പല ആവശ്യതകളിൽ ആൾക്കാരിങ്ങനെ കിടക്കുകയാണ്. അപ്പോ ഈ 3rd ബെഡില് ഉച്ച കഴിഞ്ഞിട്ട് അഡ്മിറ്റ് ചെയ്യാമെന്ന് അസിസ്റ്റന്റ് പറഞ്ഞു. അപ്പോ എന്റെ അച്ഛൻ ചോദിച്ചു, അല്ല അവിടെ ആളുണ്ടല്ലോ. അത് ഉച്ചയ്ക്ക് 2 മണിക്ക് ഡെത്താവുന്നു പറഞ്ഞു. അത് കേട്ട ഉടനെ തന്നെ വളരെ വയ്യാത്തൊരു മനുഷ്യനാണ് അവിടെ കിടക്കുന്നത്. അയാളുടെ ബന്ധുക്കളൊക്കെ വലിയ വായിൽ കരയാൻ തുടങ്ങി. അതെനിക്കിപ്പോഴും ഒരു കൊച്ചുകുട്ടിയായിരുന്നെങ്കിൽ എനിക്കിപ്പോഴും ആ ഒരു ടച്ചിങ് സിനാരിയോ എനിക്ക് ഓർമ്മ. കൃത്യം 2 മണിക്ക് മരിച്ചു കേട്ടോ. പക്ഷെ പറഞ്ഞ കറക്റ്റാണ്, ഡോക്ടറിന്റെ ഡയഗ്നോസിസ് കറക്റ്റാണ്. പക്ഷെ അത് ഈ ഒരു വളരെ കുട്ടിയായിരുന്നു എന്നെ വളരെയധികം എഫക്ട് ചെയ്തു. കാരണം നമ്മൾ ഈ ഹൃദയവും ബാക്കി അവയവങ്ങളും ഒക്കെ നമ്മൾ നോക്കുന്നു, രോഗത്തിന് പ്രതിവിധി മരുന്നുകൾ നിർദ്ദേശിക്കുന്നു, അതിനൊരു സൊല്യൂഷൻ ഉണ്ടാക്കുന്നു, രോഗം മാറ്റുന്നു. പക്ഷെ അപ്പോഴും ഇതൊക്കെ ഒരു മനുഷ്യന്റെയാണ്, ഈ ഒരു മനുഷ്യനെയാണ് നമ്മൾ ചികിത്സിക്കുന്നത്, അല്ലെ, മനുഷ്യന്റെ കാര്യങ്ങളാണ്. അപ്പൊ ഈ ഒരു അലോപ്പതി എന്ന് പറയുന്ന ഈ ഒരു സയൻസില് നമ്മുടെ ഈ ഒരു എലിമെന്റ് ഓഫ് ഹ്യൂമാനിറ്റി എന്ന് പറയുന്ന സാധനം നമ്മൾ ഒരിടത്തും പറയുന്നില്ല, അത് പഠിപ്പിക്കുന്നില്ല. അത് നമ്മളുടെ മനസ്സിനെ തനിച്ച് ഇത് അറിഞ്ഞ് പറയലാണ്. ഇതിൽ ഡോക്ടർ രാജഗോപാലിന്റെ വാക്ക് വിത്ത് വേരിയിൽ അദ്ദേഹം വളരെ മനോഹരമായിട്ട് ഇത് പലയിടത്തായിട്ട് പറയുന്നുണ്ട്. എങ്ങനെ പെയിനിനെ എങ്ങനെ പെയിനിനെ എങ്ങനെയാണ് അപ്രോച്ച് ചെയ്യേണ്ടത്. ഡയഗ്നോസിൽ നമ്മൾ രോഗത്തിനെ ചികിത്സിക്കുമ്പോഴും വേദനകൾ പലതരത്തിലാണ്. ഈ വേദനകളെ നമ്മൾ എങ്ങനെ മാറ്റും എന്നുള്ളതാണ് അതിനൊരു വളരെ ഹ്യൂമെയിൻ ഒരു അപ്രോച്ച് വേണം. അപ്പൊ ഞാൻ പലപ്പോഴും ആലോചിച്ചിട്ടുണ്ട്, മനുഷ്യന്റെ വേദനകളിൽ നെസസറി പെയിനും ഉണ്ട്, അൺനെസസറി പെയിനും ഉണ്ട്. ആവശ്യ വേദനകളും അനാവശ്യ വേദനകളും ഉണ്ട്. ആവശ്യ വേദനകളിൽ നമുക്ക് ഒരുപാട് വേദനകളുണ്ട്. ഇപ്പൊ പ്രസവ വേദന, എവിടെയെങ്കിലും വീണ് തട്ടി വീണു മുറിഞ്ഞു, അതൊരു വേദന, ദാറ്റ് ഹാസ് ടു ബി സഫർ. അൺനെസസറി ആയിട്ടുള്ള വേദന ഉണ്ട്. ഇപ്പൊ മനുഷ്യൻ നമ്മൾ നിരീക്ഷിച്ചു കൂട്ടുന്ന ആലോചിച്ച് നമ്മുടെ മനസ്സിൽ സമ്മർദ്ദം ഉണ്ടാക്കി നമ്മളുണ്ടാക്കുന്ന പല വേദനകൾ. ഉദാഹരണത്തിന് ഞാൻ 87-88 മുതൽ ആകാശവാണിയിൽ പ്രോഗ്രാം എക്സിക്യൂട്ടീവ് ഓഫീസറായിട്ട് ജോയിൻ ചെയ്തു തൃശ്ശൂരിൽ. എൻ്റെ കരിയർ ടേക്ക് ഓഫ് ചെയ്ത് അതേ സമയം തന്നെ ഏതാണ്ട് പീക്കിലേക്ക് എത്തുന്ന സമയം ഞാൻ ആകാശവാണിക്ക് കൂടി വേണ്ടിയിട്ട് സമയം നീക്കി വയ്ക്കുകയാണ്. അപ്പോൾ പലപ്പോഴും എനിക്ക് അന്ന് എല്ലാ റെക്കോർഡിങ്സും മദ്രാസിലാണ്. അവിടെ കൃത്യമായിട്ട് ചെന്നെത്തുവാനോ ഇവിടുന്ന് ലീവ് തരുവാനോ, കാരണം അന്ന് ഓരോ ഗവൺമെൻറ് സർവൻറ്റും ജോലി ചെയ്യുമ്പോൾ ഓരോ പാട്ട് പാടുമ്പോഴും ഓരോ പ്രാവശ്യം പുസ്തകം എഴുതുമ്പോഴും ഓരോ പ്രാവശ്യം വെളിയിൽ പബ്ലിക്കായിട്ട് പ്രസംഗിക്കാൻ പോകുമ്പോഴും ഒക്കെ നമ്മൾ സെൻട്രൽ ഗവൺമെൻറ്റിൻ്റെ നിയമപ്രകാരം നമ്മൾ പെർമിഷൻ എടുത്തിരിക്കണമെന്നാണ്. ലീവുമില്ല, പെർമിഷനുമില്ല. ഒപ്പം ഒരുപാട് ഭാരങ്ങളും ഉണ്ട് ഓഫീസിനകത്ത്. അപ്പോൾ ഇത് ഞാൻ ഉണ്ടാക്കിയ എൻ്റെ ഒരു നെസസറി പെയിനാണ്, അൺനെസറി പെയിനാണ്. അപ്പോൾ ഇതിൽ നിന്ന് ഞാൻ 14 വർഷമാണ് ഞാൻ വെളിയിൽ വരുന്നത്, ജോലി വിടുന്നത്. ആക്ച്വലി ദാറ്റ് അഫക്റ്റഡ് എ ലോട്ട് ഓഫ് മൈ കാരിയർ. അപ്പോൾ ഈ നെസസറി പെയിൻ ആൻഡ് അൺനെസറി പെയിൻ എന്താണെന്നതിനെ കുറിച്ച് നമുക്ക് ഒരു ഏകദേശം ഒരു ധാരണ വേണം. ഞാൻ അതൊരു മനോഹരമായ കഥ വായിച്ചു. ഒരു വലിയൊരു പർവ്വതാരോഹകനാണ്, ഞാൻ പേര് മറന്നുപോയി. അദ്ദേഹം സ്നോയിൽ കുടുങ്ങി എത്ര ദിവസം. ഫ്രോസ്റ്റ് ബൈറ്റ് കാരണം അദ്ദേഹത്തിന്റെ കാലുകൾ രണ്ടും നിർജ്ജീവമായി, ഗാംഗ്രീൻ വന്നു. അത് ആംപുട്ടേറ്റ് ചെയ്ത് കളയേണ്ടി വന്നു. ന്യൂയോർക്കിൽ എവിടെയാണ്. അപ്പൊ നല്ലൊരു വിന്റർ ഉള്ളൊരു സമയം. അദ്ദേഹത്തിന്റെ അതിൽ കൂടിയുള്ള ഒരേ ആശ്രയം ഒരു നേഴ്സാണ്. ഈ നേഴ്സ് വരുന്നു, അദ്ദേഹത്തെ വളരെ ശ്രദ്ധാപൂർവ്വം നോക്കുന്നു, ഒരു ദിവസം സംസാരിക്കുന്നു. ഒരു ദിവസം നേഴ്സ് വരാൻ വളരെ വൈകി. അപ്പൊ ഇദ്ദേഹം ഏതാണ്ട് ആത്മഹത്യയുടെ വക്കിലാണ്, മനമ്പിലാണ്. എത്രയോ നാളുകളായിട്ട് സമ്മർദ്ദം, ഒരിടത്തും പോകാൻ വയ്യ, ലോകത്ത് എന്ത് സംഭവിക്കുമെന്ന് അറിയാൻ കഴിയുന്നില്ല. അപ്പൊ വന്ന ഉടനെ നഴ്സിനോട് ഇദ്ദേഹം വളരെ രൂക്ഷമായിട്ട് അദ്ദേഹം സംസാരിക്കുന്നു. അപ്പോ നഴ്സ് പറയുന്നു, ഞാൻ ഈ ഒരു മഞ്ഞത്ത് എൻ്റെ വണ്ടി സ്കിഡ് ചെയ്തു, വളരെയധികം പ്രയാസപ്പെട്ട് ഞാനത് കൺട്രോൾ ചെയ്ത് അതൊരു ചെറിയൊരു മരത്തിൽ പോയി ഇടിച്ച് ഒരു ഡെൻഡുണ്ടായി. ഞാനിവിടെ വന്നു. ഇതൊന്നും നിങ്ങൾ മനസ്സിലാക്കുന്നില്ല, നശിച്ച മഞ്ഞ് എന്ന് പറയും. അപ്പൊ ഇദ്ദേഹം പറയും, ആണോ മഞ്ഞുണ്ടല്ലേ? അപ്പോൾ എത്രത്തോളം ഉണ്ട് മഞ്ഞ്? അപ്പൊ ഒരു വേസ്റ്റ് വരെയുള്ള മഞ്ഞാണ്. എനിക്കൊരു കുറച്ച് മഞ്ഞ് എനിക്ക് തരാമോ എന്ന് ചോദിച്ചു. ഓ പിന്നെന്താ എന്ന് പറഞ്ഞ് അവര് വെളിയിൽ പോയി ഒരു വലിയൊരു ഒരു ഐസ് ബോൾ, സ്നോ ബോൾ ഉണ്ടാക്കി ഇദ്ദേഹത്തിന്റെ കയ്യിൽ കൊണ്ടുകൊടുത്തപ്പോഴും അദ്ദേഹം പറയുന്നത്, അത്രയും നേരം ഉണ്ടായിരുന്ന വിഷമവും സങ്കടവും മാനസിക വിഭ്രമവും എല്ലാം ഒരു നിമിഷം കൊണ്ട് അദ്ദേഹത്തിന് പോയി എന്നാണ്. അപ്പോൾ ഒരു നെസസറി പെയിൻ ഒരാളുടെ, അൺനെസസറി പെയിൻ മറ്റൊരാളുടെ. ഈ ഒരു വയോധികരുടെ ഒരു ചികിത്സയും കുട്ടികളുടെ ചികിത്സയും എന്നൊക്കെ പറയുന്നത് എനിക്ക് തോന്നുന്നത് ദാറ്റ് ഈസ് ദ ഹാർഡസ്റ്റ് ഓഫ് ഓൾ ട്രീറ്റ്മെന്റ്സ്. എൻ്റെ വീട്ടിൽ എനിക്കിപ്പോഴും ഓർമ്മയുണ്ട്, എൻ്റെ അമ്മയായിരുന്നു. അമ്മ ഇപ്പോൾ 90 കഴിഞ്ഞ അമ്മ ഹെഡ് ഓഫ് ദ ഡിപ്പാർട്ട്മെന്റ് ആയിരുന്നു, മ്യൂസിക്കിന്റെ ഫാക്കൽറ്റി ഓഫ് ഫൈൻ ആർട്സിന്റെ ഡീനായിരുന്നു. വളരെ ഒരുപാട് ഉത്തരവാദിത്തമുള്ള ഒരുപാട് ജോലികളൊക്കെ വഹിച്ചിരുന്ന ആളാണ് അമ്മ. അമ്മ റിട്ടയർ ചെയ്ത് കഴിഞ്ഞിട്ട് ഞാൻ എവിടെ പോകുന്നു എന്നുള്ള അമ്മയെടുത്ത് പറഞ്ഞാൽ, ഞാൻ അമ്മയെ കൊല്ലത്ത് പോകുന്നു, അവിടെ നിന്ന് എറണാകുളത്ത് പോകും, അവിടെ നിന്ന് കോഴിക്കോട് പോകും, കോഴിക്കോട് നിന്ന് മദ്രാസിൽ പോകും, അവിടെ നിന്ന് തിരിച്ച് ഞാൻ തിരുവനന്തപുരത്ത് വരും. അപ്പൊ ഇതൊക്കെ അമ്മ ഓർത്ത് മനസ്സാകുന്ന പുസ്തകത്തിൽ എഴുതിയെടുത്ത് അമ്മ വയ്ക്കുകയായിരുന്നു. ഈ മൊബൈൽ ഇറങ്ങിയ ഒരു ടൈം അമ്മ എൻ്റെ അടുത്ത് പറഞ്ഞിടാ, നീ എവിടെയൊക്കെ ആരെയൊക്കെ ഇതിൽ വിളിക്കുന്നു എൻ്റെ അടുത്തിരുന്ന്, ഒരു ദിവസം ഒരു നേരം എന്നെ ഇതിലൊന്ന് വിളിക്കണം എന്ന് പറഞ്ഞു. അപ്പൊ ഞാൻ പറഞ്ഞു, അമ്മ ഞാൻ ഇതിലാണ് അമ്മയെ വിളിക്കുന്നത്, വെളിയിലൊക്കെ പോകുമ്പോൾ പലപ്പോഴും അമ്മ വിളിക്കുന്ന ഇതിലാണ്. അത് പക്ഷേ ഞാനെങ്ങനെ അറിയും? ഇപ്പൊ ഞാൻ അവിടെ ടെലിഫോണിന് മുന്നിലിരുന്ന് അമ്മയെ ഇതിൽ വിളിച്ച് കാണിച്ചു. അപ്പൊ അമ്മയുടെ ഒരു സന്തോഷം കാരണം ഈ വയസ്സായ ആൾക്കാർക്ക് വെരി ലിറ്റിൽ ടു ബി ഹാപ്പി. എന്നും അമ്മയ്ക്ക് ബാക്കി എല്ലാവരെയും അമ്മ മറന്നു, എന്നെ മാത്രമേ ഓർമ്മയുള്ളൂ. എന്റെ മോൻ വന്നു എന്ന് പറയും. അപ്പൊ ഒരു ചിരി അമ്മയുടെ മുഖത്ത് പടരും, ഇങ്ങനെ വിടർന്നു വരും. അപ്പൊ ആക്ച്വലി ഈ വയസ്സായ ആൾക്കാരെ അവർക്ക് വേണ്ടത് അവരെ ശ്രദ്ധിക്കുന്നു, അവരെ സ്നേഹിക്കുന്നു, അവരെ കെയർ ചെയ്യുന്നു എന്നുള്ള അവർക്ക് ഒരു തിരിച്ചറിവ് നമ്മൾ ഉണ്ടാക്കുക എന്നുള്ളതാണ്. unless you are genuine with that, അത് നമുക്ക് പ്രകടിപ്പിക്കാനും പറ്റില്ല, അവർക്കത് തിരിച്ചറിയാനും സാധിക്കില്ല. അപ്പോൾ ഇതൊരു വലിയൊരു ചുമതലയാണ് നിങ്ങൾ ഏറ്റെടുത്തിരിക്കുന്നത്. അത് എല്ലാ രീതിയിലും അത് മനോഹരമായിട്ട് ഭംഗിയായിട്ട് വിജയകരമായിട്ട് മുമ്പിലേക്ക് പോകട്ടെ. ജെറിയാട്രിക് ഓങ്കോളജി യൂണിറ്റിന് എൻ്റെ സർവ ആശംസകളും നന്ദിയും ഞാൻ നേരുകയാണ്. ഞാൻ ഒരു 4 വരി വീതം ഞാൻ പറഞ്ഞു നോക്കുകയാണ്. ചന്ദനമണിവാതിൽ പാതിചാരി ഹിന്ദോളം കണ്ണിൽ തിരയിളക്കി ശൃംഗാര ചന്ദ്രികെ നീരാടി നീ നിൽക്കെ എന്തായിരുന്നു മനസ്സിൽ. ചന്ദനമണിവാതിൽ പാതിചാരി ഹിന്ദോളം കണ്ണിൽ തിരയിളക്കി ശൃംഗാര ചന്ദ്രികെ നീരാടി നീക്കെ എന്തായിരുന്നു മനസ്സിൽ. എന്നോടെന്തിനൊലിക്കുന്നു നീ സഖിയല്ല, നമുക്കൊരു പോലെയല്ലേ. എന്നോടെന്തിനൊലിക്കുന്നു നീ സഖിയല്ല, നമുക്കൊരു പോലെയല്ലേ. അന്തയാമത്തിലെ മഞ്ഞേറ്റു പൂക്കുമി സ്വർണ്ണമന്ദാരങ്ങൾ സാക്ഷിയല്ലേ. ചന്ദനമണിവാതിൽ പാതിചാരി ഹിന്ദോളം കണ്ണിൽ തിരയിളക്കി ശൃംഗാര ചന്ദ്രികെ നീരാടി നീ നിൽക്കെ എന്തായിരുന്നു മനസ്സിൽ. ഉരുകുമെന്നുള്ളം ഉണരുമീ ഗാനം, ഉരുകുമെന്നുള്ളം ഈ സ്നേഹലാലനം നീ നീന്തും സാഗരം ഉണരുമീ ഗാനം ഉരുകുമെന്നുള്ളം. ഏതോ വാർമുകിലെ കിനാവിലെ മുത്തായി നീ വന്നു. ഏതോ വാർമുകിലെ കിനാവിലെ മുത്തായി നീ വന്നു. ഓമലേ ജീവനിൽ അമൃതികാനായി വീണ്ടും എന്നിലെ തോമകളായി നിലാവിൻ മുത്തേ നീ വന്നു. ഒന്നാം രാഗം പാടി ഒന്നിനെ മാത്രം തേടി വന്നുവല്ലോ ഇന്നലെ നീ വടക്കുന്നാഥന്റെ മുമ്പിൽ പാടുവതും രാഗം നീ കേടുവതും രാഗമ ദേവനും അനുരാഗിയ അമ്പലപ്രാവി ഒന്നാം രാഗം പാടി ഒന്നിനെ മാത്രം തേടി വന്നുവല്ലോ ഇന്നലെ നീ വടക്കുന്നാഥന്റെ മുമ്പിൽ പാടുവതും രാഗം നീ കേടുവതും രാഗമ ദേവനും അനുരാഗിയ അമ്പലപ്രാവി.
Thank you, sir, for that melodious music and also for your very insightful and empathetic words. Ladies and gentlemen, we have a small video of felicitation. This is by Dr. Jamie Abraham, who is the chairman of the Hematology Division of the Oncology Department and Professor of Medicine at the Cleveland Clinic in US. So I request,
Diagnosis of cancer at any age is not easy. But when somebody is older, it adds many layers of complexity that includes multiple medical problems, financial issues, psychosocial issues, and it's really important to look at this age group and cancer diagnosis and optimize treatment for older patients with a cancer diagnosis. I'm so glad Dr. Varun and the Medical Trust are going to start a clinic focusing on geriatric oncology. I wish you all the best and thank you for starting a geriatric oncology clinic, first time in Kerala.
Now, I request Dr. P.V. Louis to present a memento to Mr. G. Venugopal.
I request Mr. P.V. Xavier, the finance director, to present a memento to Dr. Surekha. Friends, as you know, Dr. M.R. Rajgopal was to be here this evening and join us in this program. Due to ill health, he is not able to come here, but there are two books of his. One is Walk with the Weary, as was mentioned by our chief guest, and the other is an introductory book on palliative care and Indian primer. Both books are available. They are on sale outside, just outside the hall. I request all of you to kindly buy those books, and they're really worth reading. So please do patronize those stalls. I now call upon Dr. P.V. Thomas for the vote of thanks.
Good evening, everyone. At the outset, I would like to thank Venugopal for transporting us to a different level. After hearing depressing talks on oncology, it's really refreshing to take us to a different level of relaxation. That's the power of music. Thank you, sir. That's something out of the way. Venugopal, I'm a big fan of yours. I've got his whole collection of music with me, and I'm really proud. I've heard a lot about you, and a holder of multiple state awards. But only the sad part of Venugopal is he should have got more exposure. Maybe it's the politics of music or whatever said. I am a big fan of yours. We are a medical trust are really proud to have you here, sir. And thank you, sir, coming all the way from Trivandrum to be with us today evening and transporting us to a different level of relaxation. Thank you, sir. Next, I would like to thank our team behind the whole scene. The whole gamut, what all you're seeing is only because of the big teamwork, and the main person involved in this person is our Dr. Varun. I think you need a big, Malayalis are bad in that, you need a big applause for Dr. Varun. He's one guy who's joined the institution in a very short span of time. He's made a big mark in our institution. And he's one guy you will all guys will have to watch out for. I think he's going to turn out to be one of the biggest oncologists in Kerala and one of the top oncologists in India. Shortly, watch out for this guy. He's a guy with very soft spoken, but with a very good PR and on-spot diagnosis also. From behalf of management of Medical Trust, I want to thank you, Dr. Varun, for this excellent presentation. Other guys behind the scene is, one is Dr. Deepu, always smiling, fatso guy, excellent, excellent talk for the first time. And Gino, excellent presentation, I never expected it. But one thing Gino emphasized, and what we are after is the concept the founder of this institution had started. The foundation for geriatric treatment. That is one concept, I don't know, Maya Pichan and the founder of the institution had long time back, 30-40 years, he laid down the foundation for geriatric treatment, and that's what we are, after a gap of 30 years, we are following the same thing. Hats off to that concept, and we guarantee you that we will be the forefront of geriatric imaging within another short span of time. And we want all your support, and we'll give you the top class treatment for you. Thank you.
Thank you, Dr. Thomas, for those words. And friends, with this we conclude the official inauguration. I request Dr. Surekha to please remain on stage because we'll go on to the keynote address. And to introduce Dr. Surekha, I call upon her student, Dr. Gino. The keynote address will be Geriatric Oncology and Primary Care, Forging Lifelong Partnerships.
Good evening, everyone. It's my pleasure and privilege to introduce my beloved ma'am, Dr. Surekha, to all of you. Dr. Surekha completed her MBBS in Christian Medical College, Hello. She pursued her MD in internal medicine in the same institution. After a brief stint of rural service as a service obligation, she joined back the Department of Medicine, where she was working as a clinician. Later, she had opportunities to get trained in Australia in the field of geriatrics. She also further had another exposure in United Kingdom, where again she developed more skills in geriatrics, and she came back to India in CMC, probably one of the pioneering institutions for many specialities. Geriatrics is one such specialty, which was initially started in Madras Medical College. Later, All India Institute of Medical Science and CMC joined the band, and we were one of the few institutions who were offering the course of MD Geriatrics. Ma'am was instrumental in starting the program when MCI initially approached the institution for launching the Geriatric MD program, and further from 2011 onwards, the department has been having PGs, and I joined in the year 2017. The year ma'am actually became HOD. She was my head of the department during my tenure of post-graduation. Ma'am might appear very sweet here, but she was not so when we were students. So, when ma'am is here and I present even about ma'am, I tried to, find difficulty in finding words. As you would have seen before, the presentation was very smooth, but this one I'm struggling. So, yeah. Yes, ma'am has been a center point in instituting licensed services with other departments. Geriatrics cannot remain as one department. It has to, have interactions with other departments. She started ortho-geriatrics, where we routinely see all the older adults who get admitted with a hip fracture and work in license with orthopedic service till their discharge and further follow-ups. She also started what is known as vascular geriatrics with vascular surgeons, sure ma'am is going to have a license with all the departments, and this is one thing ma'am hasn't done and I have done first. So this is Geriatric Oncology, ma'am hasn't been able to do it so far. And further, ma'am has been an advocate of multidisciplinary team. So geriatrician always has to work in license with other healthcare providers like physiotherapists, occupational therapists. She takes them during rounds, she finds patient details from them, and in our rounds, thrashes based on the inputs they give. So we have learned a lot from ma'am in how to work as a team, how to gel in as a team, and how to take things forward. She has been instrumental in organizing national and international conferences. She was organizing chairman of Gericon 2021, which was the largest geriatric conference so far which we have had in the country. She was also recognized by multiple national and international bodies. Probably the biggest of it was she receiving the President's Award for the best geriatric service in country in 2019. So, yeah, thank you so much for accepting our invitation and coming to Kochi. I hope the scene is all yours.
Thank you, Gino, for that, and good evening to all of you all. I thank the organizers, especially Dr. Varun, Dr. Deepu, and of course my beloved student, Dr. Gino, for inviting me to give this keynote address on geriatric oncology and primary care, forging lifelong partnerships. You've been through this before. More than 60% of patients who are newly diagnosed with cancer are aged 65 years or older. These older adults are very heterogeneous of each other because they have varying degrees of illnesses, which we call comorbidities, functional impairments. They can't walk because they have joint pains or a stroke or Parkinson's, and the geriatric syndromes, which Gino had alluded to in his talk. And of course, the major problem with us is they have problems with social and financial support systems. Most of our patients actually are farmers. They belong to the unorganized sector. They haven't heard of medical insurance, nor have they heard of something called pension. So they really struggle when they fall ill at the so-called ripe old age. The care of patients with cancer is very complex. Not only do they have physiological changes, like we all accrue these changes as we grow older, they also have the lot of multiple diseases, some which they actually inherit from their paramparas, some which they've taken in the form of alcohol and smoking, and the potential interaction between these diseases is actually quite difficult sometimes to balance people who have kidney diseases and heart diseases. Because of all their illnesses, they have so many medicines. And the goals of therapy definitely are different for them. Your goal of therapy may be just reaching the bathroom without actually passing urine. Somebody else's may be to climb Mount Everest before they die. These goals change because their needs change over time. And because of that, we need input from different disciplines over time. Age by itself can be a very poor predictor of who will benefit by treatment with surgery, chemotherapy, radiotherapy, and now I've heard immunotherapy. And actually listen to the lecture, Dr. Varun. Comprehensive geriatric assessment, as Gino pointed out, highlights areas. Whatever he has written down, that should be optimized before any treatment starts. So the whole load of people working together, they are primary care physicians, geriatricians, oncologists, surgeons, and a whole battery of faceless people working with loads, nutritionists, physiotherapists, name them? Name them? Gino actually said that occupational therapists and spiritual people, social workers, and they should work together to help assess and support older people with cancer. There are a lot of bitter truths. Although there has been significant work on the global landscape to address the needs of older adults with cancer, there are so many challenges. As the previous speaker pointed out, it's such a stigma actually. There should be better recognition, assessment, and management of the unique needs of these patients, and they're really unique to those patients. you should have a shared decision making. In olden days, you say, you have this pill for your fever, it will get better. But nowadays, there's Professor Google around, there's my neighbor who has another pill, so many things. So you must involve the patient, the carer, his wife, and also other people in the team, and to develop relevant goals of care that clearly reflect the patient and caregiver needs and preferences. There is a shortage of healthcare providers, leave alone geriatricians, just healthcare providers with expertise to lead the care of older patients. I am actually a general medicine doctor, but I have a passion for geriatrics. This was initiated because my mother made me actually visit her older friends. So please make it a point when you're looking out where to teach your children to visit old people, to phone them up and to say hello. It makes a big difference in both their lives. Clinical trial and enrollment has been hampered for decades by an upper age limit. Nobody wants to have clinical trials with older people. They want young, robust, lovely people to trial out their drug. And of course, financial burden. Can you imagine? They are actually thinking to balance their therapeutic cancer care with basic necessities like their son's education, their food for today, and their house rent for tomorrow. Can you imagine what a tough decision it is for the patient? So, in this video, we'll come to the third thing of the day. Really, what Gino said was, I've never done geriatric oncology at all. It's being aware of the issues of aging. That's one thing. How they age, what is the problem? And the complexities of cancer care, which Dr. Varun has alluded to in his speech, and to provide a holistic perspective for caring for older adults with cancer. So you combine the geriatric specialty with oncology, and then these older patients will receive more comprehensive assessments, appropriate interventions and referrals, and a better quality of care. That's what we aim to do. What is this optimal care? I cannot do it alone. Never. So we have to involve a whole lot of healthcare providers to provide this optimal care for the patients. The roles of and collaboration between all the stakeholders in the treatment of cancer delivery to older patients should be clearly defined. So my role is to do geriatric assessment. My role is to hold the patient's hand. Please don't step on other people's roles, and also please remember that each role is important, is very important in the care of the patient. In an attempt to deliver the highest quality, most patient and family-friendly care, a shared care of model should optimize the contributions and expertise of each discipline because they vary over time, and this should promote the most effective and seamless interaction between each member of the team. So this thing about shared care across primary and specialty interface has been defined as joint participation of the primary care physician and specialty care physicians in the planned delivery of care, and this is very important. Enhanced by information exchange. So it's basically dialoguing between these two individuals which will help to take care of the patient. In addition to routine discharge and referral notes that we send each other. So we've had shared care in many disciplines like diabetes. We have a podiatrist, we have a social worker, cardiac diseases, mental illnesses, and as Genu alluded to, orthogeriatrics. We share the care between orthopedics and geriatrics. But there is limited data on the feasibility and cost effectiveness of shared care in oncology, and what are the outcomes, have they improved or not in both the acute and chronic care settings. This shared care provides more informed patient-centered decision-making. So the ethical issue of autonomy, where the patient decides what they want for themselves, is fulfilled. There's better adherence to treatment because I choose my treatment. If I don't want it, I don't get it. improved match between older people's goals and treatment, leading to better outcomes. According to the study done by Martin et al. In Geriatric Oncology in 2018, primary care practitioners actually felt underutilized by the specialties. The communication and collaboration between oncologists and the primary care practitioners is challenging. Maybe the primary care physicians don't actually realize how much they can invest into the patient and leave it to just the specialties to look at it. But some of the oncology staff saw a need for greater collaboration. The lack of availability of geriatricians also has limited this collaboration. But the nurses perceived that they could do much more for the patient in assessment and management. And there's a clear need for improvement of collaboration to improve patient outcomes. If you look at the cancer trajectory, there are a lot of hills and valleys. From diagnosis to treatment, and then there's remission. Then, of course, there's recurrence, another remission, and they either survive or die. So, this is what the cancer patient usually faces. At the primary care level, the primary care physician meets with the patient at different points of his lifetime. He may just be a patient who came with a whole lot of illnesses to him. He may have come with a family history of cancer. What do I do now? He may come for cancer screening because he's seen from Google that we have to be screened for the various things, cancers. He may come in the middle of therapy, or he may come in remission, in relapse, or as they depart. The role of the primary care physician now stops at prevention as screening, because after that they refer to a specialist. And primary care physicians can actually offer more valuable care and support because they know the patient. Know as in not know about, they know their patient. There's a lack of understanding of disease and treatment decisions have been shown to affect older people significantly. Therefore, older people with cancer are likely to have multiple comorbid conditions, and these comorbidities should be actually addressed before treating your cancer. In geriatric assessment, Ginu has actually told us very clearly that it should be performed in older patients, not only with cancer but with other illnesses also. In 51.2% of the cases, geriatric assessment identifies abnormalities that are not detected during regular consultation. Don't think the oncologists don't do their own assessments. They do. They actually are evidence-based. They have huge numbers of ECOG, CARG, CRASH, whole lot of things that they assess for the patient. I'm not going into that detail, but I'm just saying they do not pick up, their assessments do not pick up poor physical functioning, poor nutritional status, falls, depression, and cognitive impairment, which were independently associated with worse outcomes in patients with cancer. So, multiple studies have supported the use of geriatric assessment in identifying non-cancer vulnerabilities and assessing the risks of morbidity and mortality in older adults with cancer, especially those with hematological malignancies and solid tumors. All the major organizations which deal with clinical oncology, like the SIOG, which was mentioned before, the ASCO, and the National Comprehensive Cancer Network, now recommend all patients with cancer who are undergoing chemotherapy to have a geriatric assessment. Can anybody tell me the domains of geriatric assessment? What do we assess? Except genome. The rest of you, anyone? Domains of geriatric assessment. These are the main domains that Gino had alluded to, starting from demography and going on to geriatric syndromes. Now you say, in my practice, I have so many patients, I have to do so many assessments, give so many things, and you added something more. What do? I don't have time for all this. You can also add into your paper that Gino has given you all, you can have some warning signs which actually light up something saying, oh, this patient needs more care because there's a family history of cancer. He suddenly changed his voice. Is there a cough that is very worrying? So you can add that also into your geriatric performer. The Indian healthcare system actually has a whole load of people that can help in assessment, especially now with the health and wellness clinics being on thing. But what do we have? Can you think of who's in your clinic? Who helps you in your clinic? There will be at least 1 or 2 people, the IMR maybe, or the nurse if you have one. Or you must just think of who will do all these things. Height and weight, IMR can do. Food chart is just a 3-day recall of what the person has eaten over the last 3 days. In your handout, you've got one thing called This Is Me. This Is Me just tells you what the patient likes. This can be filled up by the patient or the relative. Mobility issues, falls, memory loss and incontinence needs to be done by a nurse or a doctor. You can get your children who are on vacation to fill up This Is Me. You can get them to do height and weight and check BMIs. Please remember, with this, you're actually doing some intergenerational bonding, and your daughter and your son will feel so proud to do this assessment for you. The multidisciplinary team, you have to build one. It need not be OTPT in your clinic. You can teach anybody. My social worker can actually do a full CGA by herself, not the physical examination, at least whatever questions that are there on that sheet, she can get it done. Know the role of each member of the team. Establish good communication within the team and with the patients. And as Gino said, they feed you back with information which you wouldn't have heard from the patient, the carer, or the doctor. Suddenly one person said, "What do you want to do?" A doctor's mother was asked recently. You know what came out? The occupational therapist asked the question, "What do you want to do?" "I want to die." She has never told us that. Use screening test to select which patients can benefit from the multidisciplinary evaluation, and resolve more, refer less. So this I love. On the ward we have something called group therapy. So we actually come, or the patients, the relatives, the nurses, the nursing students, everybody comes on Thursday afternoon to have fun on the ward. A whole load of things. You can also think of that in your clinic, where you can have a movie night, you can have something called exercise, but you can make it with music so they actually groove to the beat. You can have a potluck party, games like, caroms or palangudi, local games that these people will know, antakshari, celebrate festivals and make prayer lists so each one prays for each other in times of need. This will actually motivate them and improve their quality of life. So greater perceived involvement was associated with greater satisfaction to the patients, and the majority of the patients valued the primary care physician. I like this a lot. The x-axis is time, and the y-axis, towards the x-axis, it is 100% primary care, and the other one towards the top is 100% oncology care. At the beginning of anybody's life with cancer, there's a lot of oncology care. Then they go into remission. And again, every time they have a recurrence, there's slightly more oncology care that goes on. Throughout all this runs palliative care. It may not be this linear thing, this dotted line that you see going up always. It can be pumped and go up and down as the disease wants it, because palliative care is not a write-off. It's actually symptom management, holding your hand, spirituality, and a lot more. This also tells you how much time a primary care physician spends along with the patient compared to an oncologist. So you see how much only the red lines are where the oncologist has to put in a lot of treatment. The other thing is mainly to do either combined care or with the primary care physician. So please remember, both these roles are extremely important. One gives acute care, the other one holds patient hand, supports the family, and also treats minor illnesses and comorbidities that the patient may have. This is very important because as the patient goes into the illness more and more and he's near dying, there's a shift of goalposts. It's very difficult for us as physicians to say enough of chemotherapy. Is it worth the while? It's a difficult decision for us. It's a difficult decision for the relatives. It's even more difficult for the patient to say goodbye. So this needs substantial input from the oncologist, the primary care physician, patient and family. Here at this point we shift to symptom management and maintenance of quality of life. And here we also look at other disciplines like a nurse coming home to look at a wound daily, a physiotherapist to make the patient sit up, take him for a walk in a wheelchair out into the garden, things like that. And closer to during and after death, please remember there's a family who's grieving and it's really sad. You grieve with that family. I never like to go for my patients' funerals or memorial service because they will always say, thank you Dr. Surekha for looking after the patient, and I will say, my God, all these eyes looking at me saying I've killed the patient. I'm very scared of going to these services. Implication for practice, you have to combine the principles of older care with cancer-specific best practices. But please remember, it should be the patient is first, not your evidence-based or your geriatric assessment. Understand that activities such as comprehensive assessment, caregiver support, and preservation of independence are core to that patient. I remember one patient saying, I can't imagine, he's a professor of surgery who taught me, I can't imagine that a 25-year-old girl is actually cleaning me after I passed motion. He had lost his dignity. That's really sad for the patient. Recognize that the care of the older patient often requires more time in scheduling. I take nearly 1 to 1.5 hours for each new patient, and then to look at comprehensive management strategies. So at the end, look for opportunities for greater communication. The main thing is dialoguing with patients, with the team, with your oncologist, with the geriatrician. That could improve quality of care and evolve strategies to form collaborative efforts to support the patient and their families. You know, they don't need to be told it's rocket science and you have to get this done. They just need to be told your patient's not going to suffer. It's going to be comfortable. What is the way forward? Recognize that a change is required. We have to work with a team. The geriatrician should talk to the primary care physician, and they should also talk to the oncologist to make that. A change begins with you. Recognize that the treatment goals for older patients may be different. As I told you, one person may just want to go to the bathroom without being helped or without being incontinent. The other person may want to climb Mount Everest. Personalize the care. Make them feel special. Make them realize that life is still worth living. Communicate and collaborate and share knowledge. This is what I wanted to leave with Medical Trust Hospital. It's so nice to see Gino, who's a student, flowering like this. In 2 years, he's done what I have actually worked very hard for the last 10 years in geriatrics, really. It's so nice, and I feel so fulfilled when I see this. And thanks to Medical Trust, who's actually supported him and made his dreams a reality. Thank you so much. And now it's not stopped here. It's for Dr. Varun, Dr. Deepu, Dr. Gino, and the rest of the team which I have met briefly to share your knowledge. So the next CME is going to be teaching people at the periphery how to do these things. Okay? So God bless you on your journey. You need a lot of His blessings, and may your dreams come true. God bless you all.
Thank you very much, Madam. I think that's really been an eye-opener. Can we have a nice round of applause for Madam? To make an elderly person happy is the noblest act that we can ever do. We'll go on to the last program of this evening, and that is the panel discussion. And our moderator for this evening will be none other than Dr. Shamra Menon, the very senior and elegant consultant of MTH. And with her will be Dr. Ms. Sureka, I request you, madam, to kindly remain on stage. And Dr. Ajay Kumar, consultant physician, Devi Hospital. Professor Shobha Nair, who is a professor and HOD of Pain and Palliative Care at the Amrita Institute of Medical Sciences. Dr. Suraj, who is the consultant surgical oncologist at Medical Trust Hospital. Dr. Sajesh Ashokan, consultant physician, MCS Hospital. And Dr. Varun Rajan, consultant medical oncologist. And our topic for the panel will be incorporating patients' preferences and expectations into treatment decisions. Over to you, madam. I also request Dr. C.J. John, Senior Consultant Psychiatrist, Medical Trust Hospital, to join the panel on stage.
A very good evening to all of you. You know that good medicine is always a judicious blend of the science of medicine and the art of medicine. So far you have been listening to the science of medicine, and what we are trying to do in this session is to blend the science of medicine with the art of medicine. In tune with the theme of today, there are many of us who are in the golden years, or as Varun put, cultural concepts. I like the term very much. Concept. So, welcome to all the panelists. I think without wasting time, I'll go on to the session. First, let me ask Dr. Sureka, madam, what are the objectives of treatment or the goals of treatment in a geriatric patient with malignancy?
Actually, I think Dr. Varun should say that first, but for me, it is just keeping the patient comfortable, look at his needs, what he needs best, and look at the patient's relatives' financial and social situation. And you're not going to decide, you're going to decide as a team, and that will include the strategies that they would want in oncology.
Thank you, Dr. Sureka. Now the next aspect, Dr. John. What are the usual psychosocial issues you have encountered in your practice in geriatric patients?
The frequency of depression and anxiety is very high, and if you really look at the psychosocial roots, you can understand even digesting the bad news itself can be a stress, and most of us are not trained in breaking the bad news, which is a skill by itself. And coming down, though oncology has progressed a lot, that includes molecular profiling, etc., to address psychosocial issues is a real challenge, the economic issues. And you will have the caregiving burdens of the near and near ones, and also probably the caregiving by oneself, to one's own mind, to one's own body, as the elderly passes through the process of chemotherapy, radiation and other things. It's a big challenge, and probably we'll have to address these things in a war footing so that the quality of life during the process of treatment for the elderly is much better.
Thank you, Dr. John. I think with this background, we will examine some cases. The first case, a 77-year-old active gentleman, by active I mean without any comorbidities, a very socially active person, a compounder by profession, presents to the primary care physician with lethargy and loss of appetite, and after investigations is diagnosed with carcinoma of the pancreas. He consults a gastroenterologist. He has very sound knowledge of medicine, even though he is a compounder, and has a candid discussion about the prognosis of his disease. Returns to the family physician with a request not to reveal his illness to the family till such time he thinks suitable. Dr. Ajay, what will be your approach? You will comply with the patient's request, or you will secretly inform the family? What will be your approach?
It's very confusing and very difficult question to answer because he's a compounder, he knows little bit of medicine, he would have picked up something during his career, and then he knows now that he's got a pancreatic cancer, which left to itself, like Varun said, will probably be about 6 to 8 months. Probably Varun will have a better way of treating him and getting him 3 or 4 years extended life. But the problem is not that. Invariably, some relatives also of his son, daughter, wife, or somebody will be there when he comes to see the primary physician, if it is me. And then what happens is, they will also ask what we have to, what is the problem with this man. So hiding, I don't think is a very right way of putting it. Postponing and telling the relatives at a later stage may be a solution to the problem. But I don't feel it is right that we hide the diagnosis from the relatives till a later stage when things cannot be managed at all. The present situation, you know what is happening when relatives get a little bit agitated and what they do to the hospital as well as the doctors. So it will be a little unethical as well as difficult for us if we don't actually tell the relatives as to what is happening to the patient. You will get calls, as somebody said from America, as compartments have somebody as a staff nurse somewhere, and you get a call from there, and you can't just hide them. So it will be better that you give an indication to the relatives that something is not very proper in this man, and later on we'll tell him. That's the way it should be done, I think. This is from my experience I'm telling you. I may be right, but I personally feel that hiding it from the relatives will land us in trouble.
That's only if the relatives know about it. If the patient has come to you alone.
Person has come to you alone, until somebody comes to us, we can keep quiet.
Satish, you are from a different generation.
Yeah, I agree.
The two of us. What will be your approach?
This case also is quite interesting because, see, it depends on where we are situated. So if at the periphery, I think where we practice also, we don't have too many disciplines to refer to. And most of the thing is like we are a one-man army. I think many of the physicians here, whether they're family physicians or physicians, internists, also some geriatricians whom we know are working in the periphery, they have to encounter such issues. There are two sides to it. One is the patient may come like this, and the family also may ask us not to reveal things to the patient. So in this case, it is the patient who is requesting. So if it is in our sort of setup, most probably we will be having a good relationship with the patient because he probably has been with us a long time. So in that way we will be able to earn his trust. So knowing the background of the patient is very important. From the socio-economic profile, what is his family support or what kind of a support he has. All this will help us to understand the patient's exact situation, and then it is upon us to advise the patient. See, you are encountering such a illness and it could be turning out to be serious. So we need to advise the patient to involve the family, and there may be other ethical and, as I said, ethical and legal issues also. And maybe he has to, think about settling some issues in the family, writing a will, there may be some property issues, things like that are there, which a physician or an internist can definitely make him understand. And then we could coordinate, with the oncologist or wherever he's taking his treatment. His treatment may be at a specialty center or a higher center. We can coordinate with the doctors there to make sure that he gets the best treatment. This is what we often do. And networking with doctors in higher centers is very essential for the internship.
I'm sorry to interrupt, madam. One important announcement. The owner of car number KL39R4372, your car has blocked the entrance on the road. KL39R4372, kindly repark your car.
What are the ethical and legal issues involved here? The patient's preference vis-a-vis the doctor's duty.
First of all, thank you, ma'am, for the invitation. I'm a poor replacement for Dr. Rajgopal. Nobody can replace him. Since he was not able to come today, I've kind of stepped in his shoes and attempted to answer your question, ma'am. But before that, let me congratulate Dr. Varun and the team at Medical Trust Hospital for starting this Geriatric Oncology. And I'm so proud to see Gino, who was our student at St. John's Medical College, where I was a faculty for very many years, flourishing into a full-fledged geriatrician. If you don't know much about Gino, he's also a mime artist. He writes plays, and so Medical Trust Hospital can make use of him. He can actually do, you have already used him, right? So there you go. Right, so now coming back to your question, ma'am. The first and foremost thing to make sure is that does this gentleman have compos mentis? Does he have medical, clinical, psychiatric capacity to make that decision? That's the first thing we need to do. So that actually clears the legal aspect, because if he is compos mentis, then it is his autonomy to decide whether he actually wants to disclose the diagnosis or not. Now the second thing is, why is he wanting to not tell his family? That is what we want to explore. So then comes the geriatric questions in place, like what is his relationship with his family members? What kind of financial support is he getting from them, or is he giving it to them? What are the sources for treatment, and those kinds of things need to be explored thoroughly. So here the geriatric assessment in different domains come into play as to why this gentleman doesn't want to disclose the diagnosis to his family. It could be anything. It could be because of love for his family members. You don't usually see this kind of a scenario. It's the other way around. The family members come to know about the diagnosis and they refuse to disclose the diagnosis to the patient. There's a word in psychiatry on medical terms. The word is collusion, and it could be collusion between the doctor and the patient and the nurses, the patient, the relatives and the doctors, and the relatives and friends of the family, but not the patient. So it's mostly the patients do not get disclosed about the diagnosis. It's the other way around. So here, first we need to understand why this gentleman does not want to reveal the diagnosis. Get to the bottom of this and definitely tell him, like you said, and you said, sir, that at a later date we have to disclose the diagnosis to the relatives, and we need to take that step forward in the near future.
Thank you, Dr. Shobha, but I think now I can disclose that this was a real case. This was my case about 25 years ago. This gentleman had come to me, and the reason why we didn't want to disclose his diagnosis to the relatives was the imminent marriage of his daughter, who was 39 years old. With great difficulty, he had, managed to get a groom for him. And those days there was no trust deficit. I mean, that was a good thing. And I was much younger, so I complied. I said I will not disclose. I went for the marriage also of this person's daughter. And he made it easier for me because he himself disclosed it to the family after the marriage. And then the family came to me. So there were no ill feelings on either side.
It's the greatest blessing as a physician. It's the greatest blessing as a physician.
Which attended the wedding, having the lunch.
Got it.
You attended the wedding and I had the lunch.
Yeah, I did have. No, that was the relationship between the patient and the doctor then. Now I think I'll go on to the second case. Case number 2. Here is this is a hypothetical case. 78-year-old gentleman, ex-smoker with many comorbidities, COPD, diabetes, hypertension, coronary artery disease, who was evaluated for respiratory symptoms by the primary care physician. And he is diagnosed to have stage 4 lung cancer. Here, his family members feel that he is weak and frail and the real diagnosis should not be disclosed to the patient. Now, we know that breaking the bad news is the most perfect example of the art of medicine. There are many protocols which have been popularized for the teaching purpose in the curriculum of the youngsters. Dr. Ajay, can you tell us the essence of, you don't have to narrate all the protocols, but the essence of these protocols and how useful do you find these protocols in the real world experience?
Well, I should be very frank when I say that I follow my own protocols. I don't have all these protocols because I never used to deal with much of oncology patients. But going through the net and the literature, I find a lot of protocols. And I was most impressed by one called spikes. All of them have got over 6 letters acronym so that we can get it easily done. Spikes is one. And the second one was breaks. The third one was ABCDE. Well, spikes is a 6-step protocol, which is very simple. This was step. First is setting up an interview with the patient. Second one is assessing the perceptions of the patient. The third thing is obtaining the patient's invitation. The fourth one is giving the knowledge and information to the patient. Then emotions and our empathic response to the patient's views. And finally is the strategy and planning and summary of the whole thing. This is the protocol which probably helps us most. Now what happens in arranging for an interview, most important thing is the privacy. I'm sorry to say when we tell or discuss this with our patients and their relatives, we usually have it in our consultation room, and it's probably not the ideal place where you can actually discuss all these things, because you have too many chairs to sit there, or an atmosphere which can take off or take the fears, allay the fears of the patient as well as the bystanders. But so we will have a proper interview to fix for that. Then the second thing is, after the interview, you should ask questions. When, where, who, what, and how. When is it physically right to tell this to the patient bystander? Where I told you is the privacy of the environment in which we should give this news. Who should actually break the news? Whether it should be the primary physician or the treating oncologist or somebody else. Then what is it we have to tell the patients and how much of it we should send? And finally, how to start and how to give them less stress-related response to their needs. That's regarding the setting up of the place. Then the second thing is regarding the patient perception. What the patient knows about it and what he will take it, how we will take it. Third thing is the patient's invitation, how we will get along with us. The third thing is the knowledge of the patient, how much of it we have to tell him and how much we have to hide from him. Fourth thing again is, I told you, the emotions of the patients. This is a very great challenge which we have here. The emotions can be all of a sudden silent emotion, it can be anger, it can be something else. And so we have to always respect and get this very, 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 very clearly done. Unless the patient, the emotions is at that time not looked after, he will go in for other problems. He will become angry, he may walk out, he may be crying, or sorts of, he may be doing so many other things which become beyond our expectations. So that's the emotions. And again, what we should do is, we should be very compassionate, we should very much be with him, a pat on his back, convince him that it's not all things are not bad, tell him very clearly that it is treatable and all those things. And finally, strategize and summarize. Here we should plan what all things have been done to him and then tell him in proper words how we should go about. This is the way which Spike says that how we should do it.
Thank you. Dr. Ajay, Dr. Sajesh, how do you counsel the patient? You counsel the family first, or the patient first, or both together, or you have the oncologist on board? How do you do it in your practice?
Ma'am, it depends on the socioeconomic or the education level of the patient, and also of the bystanders or the relatives, near relatives. So, if the patient has, like this patient has a stage for lung cancer, if the patient is too weak or bedridden, obviously we will not, we will respect the family members' wishes, we will not proceed much further. As best a life he can get, that is what we will look at. So, I think palliative care and minimal supportive or clinical interventions is what we will aim at. Now, if he is otherwise active and still has some aims and wishes in life, which we would like to also see him live a satisfied further life, we would coordinate definitely with the oncologist because prognostication is very important here. So after that, we would discuss with the patient's relatives and disclose what is necessary only to the patient, respecting the wishes of the family members.
There is a second clause also. Family members do not want it to be disclosed to the patient. Dr. Surekha, what roadblocks do you expect in counseling this patient? How do you circumvent them?
Thank you. One thing I find is to do it in steps. Don't give them information overload at the first time itself. And the main important thing is to listen to what they have to say. Why exactly they are saying this? What are their fears? Well, it's mentioned that he was frail and mentally incapable or whatever. He may have lots of other issues. So listen to what they have to say. What are their fears? Why did they actually say no to this? As the doctor said, that he may have been very sick at that particular point of time. The other thing is address their guilt. They may be feeling guilty. Why didn't we actually tell them to stop smoking or whatever it is? So address their guilt and tell them the benefit of the patient knowing the diagnosis. The patient knows there's something very, very wrong with him. He must be having some cancer and he's even more scared to ask, do I have cancer? Some people do ask. And to tell them that your support is essential and you have to be with the patient during this point of time. And I always think that you should ask the patient, tell the patient, because they have to write a will, as I said, and they may have a bucket list to fulfill. So I think you have to tell for me.
Dr. Varun, in your talk, you talked about some newer developments like targeted therapy, immunotherapy, etc. This particular patient, is he likely to benefit from any targeted therapy?
Yes, madam. Because it is a wonderful question. So even if it's a stage 4 lung cancer, we have to see what is the reason for the patient being so weak. Is it due to the effusion of the patient, or is it due to the bone pain? If we can address that thing, actually we can go forward because this targeted type of treatment is oral tablet and immunotherapy is not toxic. It can do wonders, not in all patients, but in certain group of patients. So we have to give the option, and even if the patient is elderly, 70, 80 years, stage 4 lung cancer, still we have to give the options to the patient.
Do you have an option for targeted therapy in lung cancer?
Definitely.
Madam, can I add one point? And I agree with Dr. Varun, because a lot of patients with lung cancer, when they are on tyrosine kinase inhibitors, or this Jeffnebs and the latest medications, their morbidity is so much less. The mortality and the lifespan might not change, but their morbidity and the kind of symptoms that they have is so much well under control. So sometimes the patients come and ask us, should we continue this medication? Because the doctor said there's nothing else and we're going to take oral chemotherapy. And we always encourage patients. Am I right, Dr. Varun? Yes. So we always encourage them. And like he said, most of our patients, when they get diagnosed at a later stage, it's so important to involve palliative care team. So that's the next target I think medical trust should have, because there's a lot of medications changes that is needed for geriatric population because of their liver dysfunction, maybe renal dysfunction, and the kind of analgesics that in what doses that these people should get is so important. And of course, bone pain is so much more prevalent with prostate cancer and other bone metastatic diseases. So I would say, I would agree with Dr. Varun to continue that target there.
Dr. Suraj, you've been sitting quietly, listening. They are very quiet people, not like medical people who just beat around the bush and went. Dr. Suraj, what about the surgical advances in cancer patients?
So I have less to talk and more to do. So cancer is not so bad in elderly as all discussed. Of course, we need palliative team, we need moral support, we need a lot of supportive stuff. But many patients are still in curable state in old age. There is a misnomer or in among ours and doctors also that when you diagnose a cancer in an old age, it's not curable. That happens only to a subfraction like a pancreas or a liver in advanced stage. But many of the oral cancers, tongue cancers, cheek cancers, breast cancers, they are easily curable, and surgery is quite possible in old age. As you know that most of the solid tumors, the primary treatment is surgery. And the surgery is quite possible in older populations. To cite one example, I will show you 2 videos. Can you play that video? So the video shows an 83-year-old lady presenting with a carcinoma tongue. What I have done is a hemiglosectomy. Half of her tongue is removed, and it's a follow-up video after 1 year. Can you play it? So you can notice that the half of the tongue is colored like skin, which is made up of her tissue. She's able to speak, she's able to take everything orally, she leads a good quality of life. Can you show the next video? You can notice that the right side of the face is less fatty. So I have used the fat from the right side of face to make her right tongue. So it is for the first the doctors to believe and then the public to believe that surgeries are quite possible in old age under the modern anesthesia techniques.
I think we don't know about the surgical part. We always say that once the patient is in the geriatric group, no surgery. Even the bystanders will not, but it is again the counseling which matters. To explain to them, how we explain to them the procedure, and we can show these videos also, to encourage them to come forward for surgery. I think we'll go to the last case. Case number 3, please. Here is a 80-year-old retired doctor. Doctors make the worst patients. Diagnosed to have breast cancer, she knows the diagnosis and she says, "Look, doctor, I have lived a decent life, and by God's grace, I no longer have any more responsibilities." This reads like a script of a play, but the summary is that she doesn't want to undergo, she knows about the side effects of chemotherapy, radiotherapy, etc. And she doesn't want to go, so she wants to have some treatment that will maintain her quality of life, but and she says, "I have fulfilled my responsibilities and I no longer need to undergo all these things." Now, Dr. John.
Various attributes whereby they are evading treatment. One could be fear, because we all doctors know
Fear of death.
He said of things, and we imagine the worst. When we have the list of medications available for chemotherapy, we start scanning the side effects and we start from the worst and think that this worst will happen to us. Probably the fear is probably warding her off. in probably using this excuse. Another thing is that many people do not want to create problems for the kith and kin. Many a times the dynamics of the family itself is altered at the face of treating a cancer. Probably the lady do not want to face that. So there could be various attributes. It need not be fulfillment. One has to really analyze and probably initiate her into treatment if it is a treatable conditions with the modern methods. That should be the key message in this.
Dr. Surekha, you must be coming across such patients in practice, need not necessarily be cancer patients. So, how do you tackle them?
Tough. Actually, I had a patient who had breast cancer. She came actually with maggots in the breast lump. And I asked her, why didn't you actually come earlier? She was a doctor's mother. She said, I've seen my daughter going through this stage of breast cancer recently and she's come out of it. I don't want the same thing to happen to me. So she had a daughter who was actually cured, but she didn't want to even show it. She didn't like that particular journey, I think, that her daughter made through this cancer. She passed away after some time. But I really don't know how to look at these people, because I guess just listening to them in stages may make something, instead of just giving what is right, what do you think is right. They have to actually grow through that disease. Give them time.
Dr. Varun, this patient is refusing treatment, but still you want to consult them, you will go after her and counsel them, because is there any need? She's a doctor, she knows everything. So, is there any point in your, going after her and trying to counsel her?
Yeah, it's a tricky situation, madam, because patient is a doctor, she is educated, she is well aware about the cancer. So first of all, we have to respect the autonomy of the patient. So that's the basic thing. But still, actually, I will try to explain, as an oncologist, what are the treatment options available, what are the possible side effects. Maybe she was talking based upon her experience or knowledge, maybe 30 or 40 years back, when she was doing her MBBS or her 20 days, or she was extrapolating these things based upon the experience from her neighbor, or as madam told some relatives. So as an oncologist, I will try to convince her once again to, and I will explain what are the options available and how it will improve her quality of life and how it will prolong the survival of the patient with a meaningful quality of life. If still she is not ready for treatment, then I will refer the patient to Shaba madam or Dr. Surekha.
I think that's true, because even if we are doctors, doctors need not know anything about the other specialities. Because there are so many recent advances, and it's always better to listen to the specialists than make decisions ourselves. Now, Dr. Surit, one thing is that this patient does not seem to be very averse to surgery. He just says that I don't want chemo and radiation. How will you do a pre-operative assessment for this patient?
Many times, she comes with a breast lump. So naturally, the treatment options are nowadays quite simple. First of all, counseling her for surgery. For example, can you show that photograph? If you neglect a breast lump, this is how the later it comes. So she has to know that being a doctor, if you just neglect a breast lump and don't treat it, final situation will be like this. But even if a patient presents with such a ulcerated breast lump, in 1.5 hours to 2 hour time, can you show the next picture? You can convert a wound exactly into a simple thing like this. It's a quite simple surgery. Mastectomy is a quite simple surgery. Most of the general surgeons also do. And being a peripheral surgery, it doesn't need a complex anesthesia or things like that. So, unless a patient is so common, like a recent MI or something like that, the mastectomy is a quite simple surgery, which is most of the time curative in all patients with CA breast. And if she is hormone positive, you can just put her on surgery plus hormone therapy, and you know that hormone therapy doesn't have many side effects like chemotherapy. Or if it's a lump, Patient just needs a lumpectomy and a hormone therapy. Many times mastectomy is not needed, like in this case. Just need a lumpectomy and hormone therapy. So counseling them what you're going to do and showing them the pictures of your previous cases, even for doctors I'm telling, is more important, and to make them understand that the things are much simpler than what you think. Many times the treatment is quite simple.
Okay. Shobha madam.
From your question, of course, it is the anesthesia assessment. You know, whether she can undergo a general anesthesia, a routine way. So most of the time in modern anesthesia, especially peripheral surgeries like breast, tongue, cheek, cancers, is quite easily curable.
I think all these 3 patients can come into palliative care. Now, what is actually palliative care? For most of us, it is going to a patient's house, changing her catheter, changing her right tube, and nothing more than that. What is actually palliative care, and what are the concepts of palliative care, and how do you compose your team? For example, if it is an oncology patient, will you include an oncologist in the team? How do you go about it? The actual modus operandi of palliative care. That's what I want.
Right. What I've seen in Kerala, because I've worked in Karnataka for a very long time, and I've come back to my home state, so for the past 3 years I'm here. So what I've seen in Kerala is, although we are educated and we have a lot of palliative care centers, even at the government level in the primary health center, what they call palliative care is exactly what you said, madam. It's changing catheters and putting an NG tube. That is palliative care. That's absolutely wrong. The concept of palliative care is treatment. So it's about the different domains that we look at of a patient: physical, psychological, social, and spiritual. Of course, we are not trained to that extent to look at the spiritual aspects, but there are a lot of questions which comes like, why did I get this disease? I've never even, I'm a teetotaler. I've never had a drink in my life. I've never smoked. It's my brother who does it, and he's a drunkard in the house, and I'm looking after my parents. He doesn't look after my parents or our parents, and I'm looking after his family also, but I've got the disease. And this is an anguish that people have, and they come up with these kind of questions. So that's a spiritual domain. But we are not there to give them solutions. We at least are listening to what they are saying. That itself is therapeutic. So palliative care, I think we should not be waiting for them to reach 4th stage or during end of life. Okay, so palliative care can go hand in hand with the diagnosis. So what we have adopted a strategy in Amrita is, when people come for chemotherapy, the medical oncology and hematology patients, we have made a deal with the oncologists and the hematologists that when they come for chemotherapy, we will go and assist them. Every chemo that they come, we don't go to the day care ward, but we go and assess patients in the inpatient facility area. We always go and assess like different things like their sleep, nutrition. Gino was explaining it very well about their food habit. Are they eating their meals regularly? What about their sleep? What about their bowel and bladder, which is very important? Do you have any pain anywhere? That's a routine question that we ask. And we pick up patients who are not actually directly referred by medical oncologists, because they are concentrating on chemo, what is the routine, what is their calculation of the dose, and looking at their blood reports and things like that. So things like the other aspects, like the functional aspect, is being missed. So we make it a point to go and speak to them, and we have an understanding that they become our regular patients, So from the early stage of chemotherapy itself, we've been integrating this kind of care in Amrita for the past couple of years, and we pick up patients otherwise that we would have missed. So physical aspect is very important. The social aspect, where you get help from the government, funds from the government and funds from Amrita itself to write off certain things and things like that. So our social worker will get involved with that. We have a full-time nurse who's trained in palliative care, looking at patients. So right now we have an 8-year-old boy. Although we are speaking about geriatric patients, we have a broad spectrum of patients under our care. So this 8-year-old boy has got a sarcoma, and he's got extensive lesions everywhere, and he's writhing in pain. So he's on a continuous morphine infusion of around 75 milligrams in a day. 75 milligrams IV infusion, that's the kind of dose that he wants. So until the nurses in that ward is strong enough to, give this kind of a medication, plus SOS medication of 4 milligrams or 5 milligrams of morphine. It's our nurse and us who actually train the nurses in that particular ward to not be scared of giving these injections. He's on top of it, he's on Midazolam to calm him down, that anxiety and things like that, because he's not able to swallow anything, and we can't put in a right strip because his platelets is very low at the moment. It's 6 or something, and he's definitely going to bleed to death. So the concept of palliative medicine is complete internal medicine, psychiatry and rehab. This is the concept that we have. Internal medicine with a lot of clinical pharmacology, because we deal with a lot of dangerous drugs like ketamine, like morphine, like fentanyl, and the kind of dose that we give for children and geriatric age group, we need to be extremely careful. So the concept of tender loving care is absolutely brilliant. It is good, but that's not palliative care. Palliative care is general medicine, pure medicine with psychiatry, with rehab, and physiotherapy and making them walk. Because we should be able to pick up when they are going to have a spinal cord compression. We should be able to educate patients. Do you have a problem with walking? It feels like heavy and you're dragging the feet. Do you have a problem with your bowel and bladder? I'm sure the oncologists are going to pick it up. But sometimes when they are referred to us for pain before, and we also tell our people to pick up those things so that we can prevent somebody from being paraplegic and bedridden. So it is total medicine, and palliative medicine should be seen in that concept. Thank you.
Thank you, Dr. Shobha. I think there is definitely light at the end of the tunnel. A positively charged healthcare team can always help the patient traverse this tunnel, of course with respectful regards for their psychosocial, religious, cultural, and of course not to forget the economic part of it. That's extremely important. They will definitely able to help these patients. I think on this optimistic note, we will end the session. Thank you all for the patient hearing, and I thank all the panelists and especially Shobha, who is here with just 8 hours of notice. Thank you all.
Thank you, one and all. I request the panelists to please remain on stage. I call upon Dr. Rose, our senior ophthalmologist, to present mementos. Dr. Rose, if you could come forward. Dr. Rose, yeah. The first memento to Dr. C.J. John. A nice round of applause. I know a growling stomach and a scowling face, but yeah, to Dr. C.J. John. To Dr. Shobha Nair. Yeah, Dr. Rose, please don't go away. To Dr. Shobha Nair. And Dr. Ajay Kumar. And I now call upon Dr. Ajay Kumar. Yes, thank you. Thank you, Dr. Rose. I request Dr. Saji, our senior cardiologist, to kindly come forward and present a memento to Dr. Suraj, to Dr. Sadish and Dr. Shamla. Dr. Sajish and Dr. Shamla. Thank you, madam, for very effectively moderating this session. And I request Dr. Gino to present a memento to Dr. Surekha. That's the student and teacher relationship there. Thank you. And I request Dr. Shamla to kindly present memento to Dr. Varun. Thank you, and I thank all the panelists once again. So before we go on to the closing remarks, I'll call upon Dr. Joseph Phillips to kindly come forward and present mementos to Dr. Gino and Deepu for their active participation and for the very good talks that we had in the beginning. Dr. Gino and Dr. Deepu. Thank you, Dr. Joseph. And it's over for the closing remarks to Dr. Deepu.
I know all of your grumbling stomachs are keeping you wondering what am I going to give the talk on. But I think there is a need for a closing remark, because for me it's a major relief that it's got on time finished. I remember my super specialty friends were reminding me, better get over 9:30 or we're going to eat you raw. So it's just 9:30, we have finished on time, and we saved the best for the last. And thank you one and all, and I'm very, very happy to say that we have almost touched 200. So that's a big number of doctors who have obliged mine and a lot of our departments personal calls to come all the way on a Saturday evening. Trust me, I am myself a very humble physician, and I know how difficult it is to spare family time on Saturday nights. Thank you. The hall is open for dinner and fellowship. Do enjoy your hospitality. Thank you and good night.
I invite Dr. Asha to present memento to our beloved Dr. Maria.
Don't miss the IMA star who did wonderfully to coordinate and MC and finish this thing on time. Thank you, Dr. Maria.
Extravaganza here, so please enjoy the music and the hospitality. We have fellowship and dinner, and as you leave the hall, there is a small gift for all of you. Make sure you collect your gift as well. Thank you very much and have a nice weekend.